Please take a seat. We are moving to start this session. You will be presenting instead of...
No. I present my presentation yesterday.
Sorry. So, the first speaker of today, of this morning, will be Victor Derautunian. Accommodation, cycloplegia. Can we expect a challenge? Please.
So finally I can catch up my absence yesterday due to delayed or cancelled flight. So I'll be talking about accommodation, cycloplegia, OFA. OFA stands for open field aberrometer. And can we expect a challenge in the future? So when we look at in trends, for trends in refractive surgery, so we see that in all continents, the number of refractive surgery increases. And I'm not talking here only about the lasers, but I'm talking about the ICL or phakic lens implantations, about refractive lens exchange, treatment of presbyopia. So in general, all the numbers rise. How do we perform refractive screening or refractive exams? So we perform a topography, we perform a tomography, either OCT-based or Scheimpflug-based. We perform a wavefront measurement, pupil size with a pupillographer, objective refraction, subjective refraction, slit lamp exam, and then we dilate the pupil. After pupil dilatation, we perform a fundus examination, and then again, at least in my practice, depending on the visual default, I perform again subjective refraction and of course in all cases objective refraction. If we want to examine the retina without dilatation, we have quite very good possibilities today. We can perform a digital ultra-wide field imaging, and as you see here, the image is great. You can almost see, I say almost, aura to aura. With one device better, with the other device worse, but still if you have a very high myopia, it's also better to examine these patients under dilatation with a contact glass. Another purpose of dilated exam is to judge the natural lens, because if we didn't dilate the pupil, we cannot look at the peripheral changes of the lens, because there we can find also some changes, early cataracts, despite the center is very clear. Another purpose of the diagnostic drops exam is to determination of accommodation. So typical in young hyperopic patients, we see very common, quite significant accommodation. So for example, on subjective refraction, we have +2. After giving cycloplegic drops, we can end up with +4 or even +5. Or in myopic people, so often we see if young people, they wear too strong glasses, they accommodate as well. So if we would just base on subjective refraction, we would end up in quite significant overcorrection. So when we look at the diagnostic exam today, so we perform an anamnesis, refraction, then diagnostics with several devices. So as you can see over here, we have multiple number of devices, autorefractor, Scheimpflug, OCT, wavefront, pupillography, axial length measurement, and then we perform funduscopy, and then at the end, medical consent. We sit with the patient and we explain the patient the surgery. My vision in the future, or I think it's not only my vision, but the vision of many people, that everything will change. So the refraction in the future we can perform half automated or automated with some devices, like here you see a device from Nidec and device from Topcon. We can perform the anamnesis online, AI refraction as I mentioned, and then the diagnostics. And I think for diagnostics what is also crucial that we can reduce it to 2 or 3 devices, like you know, in MS39 we can perform the topography, tomography, we can see all the structures inside the cornea, we can perform the meibography, we can analyze the tear film, we can measure with the new MS39 the axial length, so all sort of things in one device. And then now the second device comes in the game. So this is the open field aberrometer, which I will explain now in the next slides, and then funduscopy. then probably we can put all the data in one database, and then we could get the AI suggestions what kind of treatment we could perform. And then we can send to the patient automated based what came out here. We can send some detailed explanatory videos, and at the end we sit with the patient and answer all the questions. So we performed a pilot study with the open field aberrometer. So what was the purpose of the study? The purpose of the study was to verify and compare autorefraction, subjective refraction, autorefraction, or if we have a subjective refraction in cycloplegia, mydriasis, to open field aberrometer measurements. So we wanted to see how are the values, if they're comparable, and what are the differences. So if we looked at the simplified model of the accommodation, so we have two loops. We have a blur feedback loop, and we have a disparity feedback loop. So if we have a blur, so the system detects a defocus, the accommodation controller gives a signal, so then we have a change in ciliary muscle and the lens, and we have an accommodative response. And this center is also linked to the vergence controller, and which results in starting of the vergence. So what happens if we use just a measurement with one single eye? So it means that the target is set at the optical infinity, but we know, or the patient knows, the device is perceived as near, and this results also in accommodation, and this is called myopia, instrumental induced myopia. So what does OFA mean? How does open field aberrometer solve this problem? So an open field device allows the patient to actually look at the real object at distance through the measurement optics, and this changes everything. I don't know if you saw the OFA outside. How does it look like? So it has basically a glass, so the patient can look with both eyes at a distance, and then through optics, one eye is examined at a time. So while performing the measurement, the brain receives correct distance cues, accommodation relaxes naturally, the patient can be tested binocularly, meaning the vergence system is active, enabling a more natural response, and this removes the artificial stimulus and yields more accurate refractive results, especially for the far distance. We're not talking here about the near visual acuity. So when we look at the repeatability, which is crucial, I'm going to discuss here 3 points. One is the mean spherical equivalent. J0 stands for the astigmatism measurement of the astigmatism in the 0 and 90 degrees axis, so astigmatism with rule and against the rule, and J45 is oblique astigmatism for the axis 45 and 135 degrees. So the repeatability within the subject, it means that we compare 3 consecutive measurements, and as you see here, we have a very low standard deviation of 0.15 diopters for all 3 parameters, and the retest means that 99% of the cases are within 0.4 diopters. So here are the results. So here, when we compare the OFA measurement to the manifest subjective refraction, we have a very good agreement. So you see that the very good correlation. When you look at the lower graph, this is blend Atmal graph, it shows that the difference of the mean spherical equivalence is almost 0, so we didn't find here any bias. We found also very nice results for the astigmatism with rule and against the rule. However, there is a bigger spread in the oblique astigmatism because the perception of this oblique astigmatism in the subjective refraction is diminished. So here we have the results comparing objective mydriatic refraction to the OFA measurement. So the results are even better, resulting with a much lower spread. And here we have 2 groups. Patients in blue are below 40, and patients in red are over 40. and just look at the range of the diopters. We're ranging from around -12 up to +9. So we're covering basically, I would say, most of refractive errors. So as a conclusion, so even compared to the objective cycloplegic refraction, which is often considered as a gold standard, the OFA performs extremely well, especially for spherical and for regular, for the sphere and for this regular astigmatism. This further validates the OFA as a reliable physiologic and efficient tool for refractive analysis without the need for pharmacological dilatation, and further studies for segmented visual errors age-matched are required. Probably we will need some increased precision and nomograms, and also this might simplify in the future the refractive exam, because we will get the numbers right after, and the dilatation, probably we would need to dilate to verify the lens, to verify the peripheral retina, but for the visual exam it will not be required, or we will get quite idea of the accommodation, and this will, I think it's going to be a game changer. Thank you very much.
Thank you very much. Thank you very much. Really excellent study comparing everything. Very interesting. I have one observation we made. We are doing frequently femtolaser cataract surgery. And after the docking, we can see the lens. What I observed that myopic patient that after my test, I understand I was overcorrected, or hyperopic patient, the lens is much thicker than usual, because probably having passing many years of a ciliary body in constant contraction, the lens grows more anterior-posterior than by side. So that could be something that we have to look. How thick is the lens to understand if they are overcorrected? They use standard accommodation.
So combining with the new MS-39, I think it's not going to be very difficult, because we have all the data. It just needs to be calculated and compared.
Thank you very much, Victor. My question is, first thing, maybe you showed it and I missed it, but is there a comparison of the data in the same patient taken with the Peramis?
No, no,
Not yet.
no, not yet.
Would you expect a large shift because of instrument myopia?
Definitely, definitely. Always when you examine one eye, so you see, even if you, I mean, without having prior this device, when you do the binocular adjustment, so you see that you can relax the system. So I expect also that there will be some differences compared to the monocular system.
Oh, the next speaker is Ivan Gabric. No? Okay. Is Riccardo Vinciguerra, keratoconus artificial intelligence, K, a new index to detect keratoconus.
Thank you very much. So it's a pleasure to show this is extremely new. These are my financial disclosure and they are not relevant. So let's speak about OCT for the diagnosis of corneal ectasia. We know that OCT is the leading technology for anterior segment imaging because it has high resolution, because it is able to measure epithelial thickness, and because, and this is not a minor thing, it's able to track posterior surface much better than any other device. But then, we also know that anterior segment with OCT is not the gold standard for ectasia detection. So why is that so? So why do we need OCT? So OCT and epithelial map is a fundamental confirmation diagnosis, and epithelial maps increase mostly specificity more than sensitivity. Let me explain you why in a couple of cases. So this was a 49-year-old female that was referred to me for unilateral keratoconus. And if you look at the topography, you can clearly see that the left eye is normal. The right eye, there is an abnormal front surface, but the back surface is normal. So if you look at the epithelial map, she had a very, very thick epithelium, which rules out the diagnosis of keratoconus. Then I went back to the room, spoke with the patient, and she didn't mention that many months before, she had an incident in her house with boiling oil, but she forgot about it because the decrease in vision happened many months after. So I suggested to remove the epithelium, and now she's 20/20 unaided. So what about epithelium in keratoconus? How can we use it to help us? Let me show you this case. So this is a very asymmetric ectasia that I've seen a couple of weeks ago. The left eye, that is on the other side, it's a clear keratoconus. The other one, from my point of view, is absolutely normal. And I had to remove posterior elevation just because otherwise you will see epithelial thickness. But posterior elevation is absolutely normal. But in this case was one of the first time in my life in which I've seen that epithelium really did make the difference. It was the only thing that changed in the unilateral keratoconus. So I guess that yes, epithelium can help us. But epithelium in OCT has many papers, but none is really the gold standard, and there is very few available. So there is the score system from anterior, which doesn't have epithelial thickness, and then there is the MS39. The CSO native algorithm has been updated this year with this very recent publication, and is a neural network. This is how you see it in your platform. So how does it work? Basically, the neural network will classify the eye whether it's normal, keratoconus, abnormal, suspect, or myopic post-op. So when I've seen this, I've seen a potential issue. That is, what about if you have a patient that is coming to you to have refractive surgery and is abnormal or suspect? Do you do the surgery? Do you don't do the surgery? You do other surgeries? So my idea was, let's create something that is similar to what we have, for example, in the Oculus platform, like the CBI, that is 0-1. So that was the idea of the study. Obviously, these kind of studies need a lot of friends. So I asked for help around the world. And the aim of the study was to create a new artificial intelligence OCT-based index to detect keratoconus. Farad was part of the study. Arbelites was part of the study. Alio was part of the study. So it was a very, very big team, Dresden, because we needed a lot of patients. And when I say a lot of patients, I really mean it. So we are speaking of almost 4,000 patients. Really a lot. And we included 411 patients like the one you have seen before. So one eye abnormal, the other eye normal. But then there is the issue of how we define a very asymmetric ectasia, because there is this paper from Bradley that said KISA score is not good to use it. And I partly agree. But then there is this other paper from Renato that is saying that subjective classification is not good. And I also agree. So I agree with both. So what did we say? Okay. So there is only one way. We use everything from both worlds. We use the subjective classification, which is the topographically more normal looking eye of an asymmetric keratoconus. And in addition, we applied the KISA score to be sure that the subjective classification was also confirmed by objective classification. And the good thing is that it looks like that the masked cornea experts were good, because we had only to exclude 3% of the cases. Let me show you some examples, because I want to be 100% absolutely clear with you. Very asymmetric ectasia are not normal eyes. Some of them are. They are like an eye of anyone you know. But some of them do have abnormalities. But they are great, because we have to teach to a neural network what is normal and what is abnormal. If you give to the neural network something that is still normal, you're not teaching anything to the artificial intelligence. So you need a spectrum of disease that goes from super normal to very abnormal. And you need something in between, and these are the very asymmetric ectasia. So again, very asymmetric ectasia, they are not normal, they are more normal than keratoconus. Some of them, like this one in the right, is just astigmatism, but the other one you do see asymmetry. So the statistical analysis was a multi-layer perceptron network, which is the same kind of neural network we used in the first study. 80% of the database was used as training, and 20% randomly selected as validation. So I'm going to show you only the result of the validation, because the training set is useless from the point of view of how it works. So this is the ROC curves in clear keratoconus. So we had 100% of sensitivity and 97% of specificity. And you can see the other indices that are inside the CSO platform. Obviously, since we are speaking about clear keratoconus, they kind of overlap. But what is interesting here is the next one. So here you see keratoconus, normal and very asymmetric ectasia in the box plot. You can see that the separation between the groups is very clear. So if you want to draw a line wherever inside, you can see that it's quite clear that you can separate normal from everything else. But I will show it to you even with the ROC curves. So this is the ROC curves of the KI index that has a sensitivity of 78% and a specificity of 93 for those very asymmetric ectasia I was speaking before. ROC curve of 0.887. Again, how these look like. So you can see this is right, left, right, left. You see that some of them are very normal, some of them are more abnormal. Obviously, I'm showing both eyes here. So one eye is a clear keratoconus. Important clarification again. I really like to reiterate these. Very asymmetric ectasia are not completely normal. And it's obvious that experts will be able to see abnormalities in these eyes. The idea is that we are trying to teach to a computer to be as good as an expert, but without bias. And it's almost important that almost all the time keratoconus will be bilateral. Even so, some eyes will be phenotypically normal with any technologies. So I have another new thing to show you. We also did a comparison with other technologies in an external validation. So we took another data set, we applied the index, and we have seen how it performs compared to the Oculus platform. In particular, the CBI and the TBI version 2, which is the one that is recently the update. And this is an external validation from Dresden University with 75 normal, 94 keratoconus, and 45 very asymmetric ectasia. So it's a quite decent database. It's not a small one. And you can see that if we evaluate keratoconus, the KI index was significantly better than the BED-D in terms of the long curve and not inferior to all other indices. However, as you can see from the ROC curve, which is the blue one, there is a tendency to be better than any other index because there is a quite clear-cut separation between CBI, TBI, and all the other indices. But what it becomes even more interesting is when we go and speak about very asymmetric ectasia, because KI index was superior to BED-D and to PRFI, the one created with random forest, and not inferior to all other indices. But again, as you can see, the blue one is quite separated from everything else. And what I really like a lot is that you can see that the KI index tends to go all the way up and then on the right, which means that we will not have a lot of overlap. That's the clear cut. So the clear cut will be 0.5 most likely. So as a discussion, the results of KI index are very promising to detect keratoconus and early ectasia. It is superior to BED-D and PRFI, and is comparable / slightly better than the TBI version 2 and CBI. My idea is that that is possibly due to the posterior tracking curvature detection, which is better, and epithelial maps. But more studies will be needed. Thank you very much.
Okay. Riccardo, sir, I would like that you make some comment about a point. Very asymmetric ectasia are patients where both eyes are not normal, and the system can detect both. I believe that this is very important because at some stage, the worst eyes look like the better eyes in the very early stage. And you are able to detect this stage because it's easy to say, oh, this is a very asymmetric eyes because I see one eye with keratoconus and the other look normal. But the challenging point is pick the patient when both look normal.
Yes, yeah, absolutely. Obviously, from the point of view of creating an index, we do need the other eye to be abnormal so we can say, well, genetically speaking, these eyes should be both abnormal. But I'm sure that when this technology will be launched, we will be able to use this technology in eyes that are abnormal. And the good thing, and that's, I think it will be a great add-on, is that obviously we will be able to back calculate this index even in patients that had the MS39 long time before. So imagine that you have a patient that developed ectasia even many years ago. We can look if the KI index was abnormal in these patients, and we can back calculate then. So that I think will be the great benefit. We can see whether we will be able to see abnormalities in patients that develop ectasia.
Also, what you mentioned, say yes or not, because some indexes make you in trouble because you say, oh, can be, I don't know, is unsafe. You clearly state if yes or not.
Paolo, thank you very much. Riccardo, thank you very much. Where do you see the clinical need for Scheimpflug imaging systems now? Is it densitometry and wound healing monitoring, or what else makes it a useful tool?
That's a complex question to an Oculus advisor.
No. Scheimpflug. So
yeah, I know.
Serious. CSO has the serious.
But
why do we need the serious if we have the MS39?
I don't think we do. I don't think we do need the Scheimpflug anymore.
I see a point because for the OCT that working in invisible light, what look to be transparent in the OCT is not transparent optically. So if you want to know if this impair the transparency, you should have a Scheimpflug. If you want to make an analysis of the tissue, you need an OCT. So there is still a space for that.
And the next presentation will be given by Dr. El Sayad, MS39, to guide diagnosis and surgical indications.
Good morning. My name is Fouad Al Sayed. I'm a cornea cataract and refractive consultant in Cairo, Egypt. And unlike most of the speakers here, I'm actually a recent user of MS39. I've just had it for the past 9 months. And I like to know how the devices work. I did a research fellowship in OCT back in Bascom Polymer before my residency. So like Eben was mentioning yesterday, I always like to know how the devices work. So I have no financial interests. So the way I set up the MS39 is I have my investigations room, which has the MS39 and the Osiris, and it's not in my clinic. I remember some doctors like Dr. Dan Reinstein has the MS39 in his clinic. And I have my room set up that I have a dual screen monitor, and I have the EMR in one screen, and then the Phoenix software, the workstation. And that's been a big game changer for me, using the Phoenix software itself. Because a lot of doctors in Egypt, we only have 5 MS39 in Egypt as of yesterday, and they use just printouts, and the printouts doesn't really provide you all the necessary info. So I like to use the workstation itself. And for those who haven't used the device, I'm going to actually use it. I'm going to show you like the basic acquisition features. So here, this is what you see when you're on the device. You have the different measurement scans, and what I recommend based on what Francesco told me is the 10mm scan. It takes 12 radial scans 5 times, and this is good for refractive screening and for monitoring your keratoconus patients. Now, as a cornea surgeon, I also like to have a wider view. I like to use the 16mm scan. It takes a little bit less resolution, 12 scans also, twice, and you can get the angle-to-angle measurements, and this is important to get the scleral spur measurements for the ICL algorithm. And also you can see the front of the lens. The next option is the anterior segment OCT scan. This is if you want to get more details. Like I tell my technician, I want you to scan this specifically. The HD feature takes 10 scans. And you can also 10mm, and right now you'll see a wider view when you switch to the 16mm. You can actually scan the front of the lens, and you can go back to the back of the lens to see like specific cataracts or something. And you also have different options. You could do one scan. I'll show you right now. And so 1, 4, and 2. I don't usually do the raster or the sector. It takes too much time, especially the 360. You need like a patient to be still for at least 5 to 10 seconds. So I rarely do this. And I'm not going to mention the biometry. I think the new one has newer software than this, and it's actually a biometry. Pupillography, I do it for all my refractive patients. And this is the printout. It shows you the scotopic, the mesopic, and photopic. And tear film analysis, I love to do the keratoscopy. It tells me how clear the cornea is, and it measures an objective measurement of the tear breakup time. So now I'm going to show you a few cases that I've seen over the past few months. This is a 36-year-old female. She had LASIK 14 years ago and repeated a PRK 14 months ago. Both were done elsewhere. And you could see this diffuse reticular haze. We have a lot of sun in Egypt, and she wasn't very compliant with wearing her sunglasses. So uncorrected visual acuity, 0.05 decimal. Refraction on the autograph is -7 with the best corrected visual acuity of 0.2. This is grade 3 haze. So this is what I see on the MS-39. This is like a video. I like to scroll with the mouse, see the subepithelial fibrosis. You can actually measure it. I don't show to show the exact depth. And what's beautiful about the MS-39 is the correlation to the tomography. You could see the epithelial map shows this diffuse epithelial thickening in the center here. So I recommended for her to do just a superficial keratectomy. I didn't want to do a PTK because I was worried about her non-compliance and having recurrent haze. So I did a keratectomy using a hockey knife and a crescent blade. And the most important thing here is the mitomycin C. It's not your usual 20, 30 seconds. I applied it for 2 minutes. Rinsed with chilled BSS, and the regular postoperative regimen with some vitamin C, turmeric, and acetylcysteine. Some papers have shown that it decreases fibroblast proliferation. So 4 days, vision's improved to 0.3. Refraction is plano. She's happy, and she's slightly amblyopic too. So before, you could see here the haze, and 2 months post-keratectomy, uncorrected visual acuity is improved to 0.6 with a planar refraction. The haze isn't completely gone, but it's much improved compared to preoperatively. And the epithelial maps have improved significantly, not back to normal completely, but definitely an improvement. So even before surgery, I do a lot of cornea transplants. If a patient has synechia, I like to plan to see where the synechia is. Is it ranging from 10 to 12 degrees? You could do it with the 360 scan. And post-synechulitis, you could now continue doing either endothelial keratoplasty, whether it's a DSEC or a DMEC. Also, I have a lot of patients who come in referred for a PKP, but I noticed that because this patient, for instance, had long-standing fuchs dystrophy, I do a superficial keratectomy at the slit lamp just with a cotton tip, but the OCT would help me know even beforehand if this patient has significant scarring or not. And instead of doing a PKP with 16 sutures, I just did a DMEC on this patient. And you could see here that the scarring is mainly superficial. This is another patient. He's got some scarring, referred for possible DMEC versus PKP. And with a superficial keratectomy, he's got some deep scarring there, but not too deep. You could treat that with a PTK. So I offered him the option of doing a DMEC first, and if needed, we could do a PTK. No need to do a complete full thickness graft in this case. Another patient referred to me, 37-year-old, history of a PKP transplant 14 years ago, referred for a repeat PKP. However, you always need to do an OCT on these patients. So you can see here she's got a very thick scar, and an OCT, it's extremely thick, but it's all subepithelial, and you could see a clear zone of cornea below it. So I wouldn't rush to do a repeat graft in these patients. I'd refer them again. I would actually do a superficial keratectomy. And this is what I did in this case. I did a keratectomy, and you could see her vision improved from count fingers to 0.3, and I saved this patient undergoing another graft. And like I said, the setting I use most is the topography setting, the regular one. I don't know if I play the video here, sorry. And once you're inside here, can you play this video? Okay, but you press on the button on the sections above, and you could actually see that she improved her OCT. So I'm going to skip this video for now. Also, another thing, this is a patient who had one of these cosmetic iris implants a few years ago. Unfortunately, they've been banned now, thankfully, in Egypt. A little too late. But she had LASIK, and she had interface fluid syndrome. And I was going to do a DMEC for her, but I ended up doing an ultra-thin DSEC. And you can monitor with the OCT here. You could see that the DMEC is well attached, the DSEC is well attached, but she still has the interface fluid syndrome. And even 1 week post-op, the fluid's not gone. It could be PRISC, pressure-induced stromal keratitis. I started her on IOP lowering medications. But even post-op month 1, the vision's improved significantly, and the graft's well attached, and the interface fluid has disappeared. So I always rely on OCT pachymetry for post-grafts follow-up. This is a patient who had a corneal graft, PKP, excellent vision, very happy with it. And then he comes in a few weeks later complaining of decreased vision discomfort. You could see a loose suture superiorly, and this faint line, the could reduce line, which indicates early graft rejection. And I like to follow these with OCT pachymetry. This was actually with the Solix OCT, which I have before I got the MS39. And you could see here superior edema at the loose suture, and inferiorly where there's early graft rejection. Once I started this patient on intense steroid regimen, the edema had gone. And it's before you even see the patient in clinic, you do a pachymetry, OCT pachymetry, or topography, and you'll know that he's better. And I like to always monitor these patients with OCT. This is another patient, 55-year-old female, Fuchs dystrophy. I did a DMEC in the right eye, a DMEC triple in the left eye. Pretty happy with the vision. She had dense Fuchs dystrophy, and she comes in 4 months later, excellent vision before she travels. A few days before she travels, and I see this faint line of KPs. I tell her she needs to be followed up closely, but she travels anyways, and she comes in 2 months later with a full-blown graft rejection, count fingers vision, and diffuse KPs. The pachymetry obviously shows you here that although she had early edema, she went on to have a full graft rejection. So I started her on 10 steroids and sodium chloride. You could see 1 month she started to clear her graft edema. And it's also nice to always monitor these with OCT pachymetry. You could see that it decreased and her vision improved. So what if, I always say, for graft rejection, you need to always detect it early. That's what makes the difference between graft failure and back to having a normal graft. So this is a recent patient I just did a few months ago, 70-year-old male. And I used this large S mark because I did it in an outside hospital and they have a big mark, which I don't prefer to use. And I don't know why the video is not working here. So in these cases, post-op day 1, I always schedule them for like a topography. And you could just tell before the patient comes in, the graft is well attached. You could see the air bubble here, the correlation, and I'll feel better knowing that this graft won't need a rebubble. But 3 weeks post-DMEC, same situation. Diffuse KPs around the S mark indicating an early graft rejection. And you could actually see this on the OCT. You could detect early graft rejection on the OCT. If you look carefully with the built-in zoom function, you could see here the thickening of the Descemet's endothelial complex. And you could see the signs of the KPs in the endothelium. And this is like a big thing where you can actually detect early graft rejection. And in fact, my colleagues in Bascom Palmer did a study about this. They had their own OCT device so they can customly design, and they've published a few papers in ophthalmology and AJO measuring the Descemet's endothelial map. Very similar to epithelial mapping like we have, they actually were able to separate the Decimase endothelium complex from the stroma. And this, like on the left here, you can compare the normal to the Decimase endothelial complex. And this here indicates early endothelial rejection. You could see that the Decimase endothelial complex is thickened in the red area compared to the total cornea. And like I mentioned, if you detect graft rejection earlier, you're much more likely to save the graft from graft failure. And this is courtesy of Dr. Mohammed Abu Shusha, one of my colleagues in vascular compartment. So just to summarize, MS39, you need to utilize the different features, whether it's a 12 by 5, 10 millimeters refractive keratoconus patients or the larger angle to angle for ICL measurements. And this could be easily chosen from the topography. You just tell your technician or optometrist. And OCT in general helps me visualize as a corneal surgeon the stroma, the angle, the graft-host junction for PKPs, to follow graft failure and hopefully early detect even graft rejection. And what's unique about it, you can correlate all this to topography. Thank you so much.
Thank you very much. These were extremely interesting cases showing the potential of and the versatility of the device.
Thank you.
Are there questions or comments to the cases or the use? Samar Hamada has a question.
Thank you, very good presentation. It's not a question as much as emphasize the point you mentioned about using your MS39 measuring pachymetry maps to monitor those patients. And we've seen many cases, probably seen complicated, where you can't decide the failure of graft, especially when we talk about DMEX. And I think the only monitor here is usually corneal thickness. And sometimes localized swelling, what you showed in your, it show you where the problem is, could be actually detect early rejection without actually seeing where those could have this line. Right. You could be actually to look about detached DMEC, for example, when the visibility is impossible. Yeah. So it's a very powerful tool, must say. Thank you.
Exactly. Thank you so much.
Thank you. Next speaker will be Professor Farada Fezzi, PACE, cross-linking to improve vision.
I think we wanted to. Shall we do? We have Juan Arbelais, who is not with us this morning, but we have a pre-recorded talk. I think they already prepared it. Is he live? He's live. Sorry, so we continue with Juan Arbelais, assessing the repeatability of MS39 in keratoconus, a multi-center study.
Okay, good morning, Farhad. Good morning, everyone. Thanks for the invitation. Unfortunately, I couldn't be today sharing this meeting with you guys in presence, but I will hope that this presentation will add it to the program of the meeting. You guys can hear me well?
Yes. We hear you loud and clear, Juan. Good morning.
Okay, good morning. So I will share the study that we did assessing the repeatability of the MS39 measurements in keratoconus in a multi-center study. These are my financial disclosures. I consult for CSO. This is the only relevant financial disclosure for this presentation. Keratoconus is a progressive corneal ectasia leading to thinning, protrusion, and visual impairment. It's important the early detection and accurate monitoring are crucial for disease management and preventing progression. For example, with a corneal cross-linking to have an early intervention. The current progression criteria heavily rely on sham fluke technology, but it has limitations. It has limited measurement repeatability, especially in advanced cases of keratoconus, and it applies a uniform standard across all disease stages, in early keratoconus, in moderate, and in advanced, despite the varying noise levels in each of these stages of the disease. So many of you would consider this is a normal topography. So we work starting from 2018 in a group with Francesco Versace, Dr. Ala, Dr. Jorge and myself, and we managed to produce an artificial neural network that is used for automated keratoconus detection using the MS-39. With this neural network, we are able to obtain a classification involving various keratoconus indices that uses the MS-39 for the detection of the keratoconus. In this case, we clearly see the points that are relevant in this early case of keratoconus. We can see that all the points are confluent together in the top right image where we see the Placido disc, and we can see that it's producing the classification a case of keratoconus suspect. And for those who were skeptical and say that this is still not keratoconus suspect, this is the fellow eye of the same patient. So then we got together to assess the measurement repeatability by keratoconus severity using the MS-39 between myself in cases from Oman, Robert Herbert with cases from Germany, Jorge Alió from Spain, Ricardo Vinciguerra in Italy, and of course with the help of Francesco Versace from CSO in Italy. As we all know, the MS-39 is an anterior segment OCT that has a high resolution and spectral domain OCT that is coupled with Placido disc. These are the characteristics of the OCT and the topography. The MS-39 has an interesting feature. It uses Gaussian curvature. The curvature indices of the MS-39 are not based on the well-known definitions of curvature. In fact, traditional measurements like axial and tangential curvature measurements measure the shape of the cornea only in the radial direction, which is desirable for the optical purposes of which topography was developed, but is not sufficient to describe corneal morphology exhaustively. To this end, it was decided by CSO to use the Gaussian curvature, which by definition is the geometric mean of two principal curvatures at a given point. This curvature, in addition to considering all spatial components, has among its various characteristics the ability to mask toricity, given that it averaged the two main curvatures. While this is unacceptable if we want to describe the refractive behavior of the cornea, it is desirable if we use curvature for the diagnosis of keratoconus. The purpose of our study was to evaluate the repeatability of diagnostic indices for keratoconus screening using the MS-39 across different keratoconus stages. And the secondary aim was to establish severity-based thresholds for progression detection, enabling personalized criteria for keratoconus management. We did a retrospective multicenter cohort study, and we included 1,103 eyes of 709 keratoconus patients. The inclusion criteria was basically patients diagnosed with keratoconus using the MS-39 by a cornea specialist, and the exclusion criteria, as it's mentioned in the slide: previous corneal interventions, concomitant ocular disease, inability to fixate, insufficient tear film, other ocular disease, or corneal reflex issues. And the data acquisition was based on 3 high-quality scans per eye using the MS-39. The indices evaluated were in 3 groups: curvature indices, elevation indices, and thickness indices. They are listed here in the slide. We evaluated for all of these indices the repeatability, and we use mean values within subject standard deviation, coefficient of repeatability, coefficient of variation, and we identified the outliers using interquantile range. The method was using 1.5 times interquartile range outside the 25th and 75th percentiles. With these, 263 eyes, which is 20% of the sample of the study, were excluded as outliers. In these graphs, excuse me. In these graphs, we can In these graphs, we show how the repeatability and the coefficient of variation behaves. The steepest part of the cornea changes as keratoconus gets worse. When the steepness is low, for example, in cases of mild keratoconus, the machine gives very consistent numbers. But as the cornea steepens, it gets higher, more severe cases of keratoconus, the measurements vary more. So, the more advanced the disease, the less consistent the steepness numbers becomes, and we need to be more careful when interpreting a steepness in advanced cases of keratoconus, because the small changes may just be measurement noise and not true progression. And the same apply, and the same is shown here for the corneal thickness in these particular graphs, and the central corneal thickness. And these are all the other parameters we evaluate, some of the other parameters, other indices we evaluate in different keratoconus stages, in different ranges. So this is a very nice graph that has a comparison of progression cutoff values in keratoconus using Scheimpflug based on literature and publications, in particular with the Pentacam and the MS39. So we see for cases where the Kmax is below 49 diopters, the two devices perform similarly. But when the Kmax increases between 49 and 54 diopters, for example, with the Pentacam, we need a change of 1.4 diopters to diagnose progression, when with the MS39, just with the 0.8 diopters, we can already start identifying progression due to the higher repeatability in more advanced cases. And when the cornea, the Kmax value gets even steeper, in cases where it's above 54, the repeatability of the Pentacam fails more, is less repeatable, so it's required 1.62 diopters to evaluate a true progression, while the MS39, even up to 62 diopters, is still very close, almost 0.9, less than 1 diopter for us to identify progression in these cases. And the same happens, we have highly repeatability in corneal thickness. In thin corneas, even with changes of 7 microns, we are already able to identify progression, whereas with the Pentacam, we need changes in 15 microns of thinning to identify progression. This is how the keratoconus follow-up display looks like now. We see two lines, two red lines, and whatever is outside of these red lines is what we should consider progression. We see the maps in the right side, and as all of you users of the MS39 know, that we can also check and see all of the maps that are available in the MS39 to see them, the color graphs in the right. For example, here I changed to tangential anterior to pachymetry maps, and in this case we have a true progression where it was significant in almost all the parameters that are shown in the graphs in the left. So as key findings and comparisons, we have high repeatability of the MS39 that was demonstrated across most keratoconus diagnostic indices, especially in mild to moderate stages. And the severity-dependent variability, the repeatability depends on the magnitude of each parameter, which increasing the CR in more advanced cases, as we already have shown in the previous tables. And when we compare with Scheimpflug technology, our study suggests that the MS39 offers higher repeatability, especially in advanced cases, moderately than advanced cases of keratoconus. For example, a Kmax, in Kmaxes of more than 62 diopters, the MS39 has a CR of 2.31 diopters, whereas the Scheimpflug has a CR of 6.25 diopters. In milder keratoconus cases, the repeatability of both technologies appear comparable, and above Kmax values of 50 diopters, the OCT shows significantly advantages. What implications we have now for progression criteria? Our findings support that there are device-specific progression thresholds that we need to consider, that the MS39 may allow for lower detection limits, enabling earlier confirmation of progression, which is important in a disease like keratoconus. And As I say, for example, in cases with Kmax of 55 diopters, with MS39 we can identify progression even with 0.9 diopters of increase, whereas with the Pentacam we need 1.3 to 1.4 diopters. In conclusion, the anterior segment OCT, the MS39, demonstrated high repeatability across key diagnostic indices in keratoconus, even in advanced stages, and this technology is a reliable tool for tracking keratoconus progression and assessment of assessing treatment outcomes. Despite the increased variability that we saw in cases, especially in the posterior elevation and corneal thickness in advanced cases, the MS39 still provides precise measurements that are crucial for clinical decision making. And as a recommendation, we have to consider the relationship between disease severity and the variability in diagnostic indices when evaluating keratoconus, establishing stage-specific thresholds that can aid in distinguishing true progression from normal variability. Thanks for your attention.
Thank you, Juan. It's a pity you couldn't be with us. Are there questions from the audience? How many of you have both a Scheinflug system and the MS39? So how do you deal with repeatability when you see a progression on Scheinflug and then see a progression in the MS39? This will be published, but I constantly have to think of how steep is this cornea, how much can I forgive the repeatability? Ricardo.
Well, so we have this software since quite a while, so I'm relying on the MS39 since about 6 months. So in patients that I have a previous Scheinflug, I do both. But once I have the MS39 scan, I don't scan them with Scheinflug anymore.
And then you won't have, but you still do the Corvis?
I do the Corvis and the MS39. Yeah.
But remember that when you have a patient that have even mild opacity, the Scheinflug missed to check the posterior surface. So you already know that will be not a good measure.
One announcement to make on behalf of CSO Italia. The shuttle bus will leave as planned and scheduled at 1 p.m. from here. And CSO is asking you, anybody with a different schedule, needing to leave at a different time, should contact registration.
I would like to share my personal experience based on the question that you asked, Farhad. So, for example, we stopped using Pentacam already since many years ago, approximately 2014, and we heavily relied in the series since then. We used to perform Pentacam Scheinflug imaging and also Scout Placido imaging to all the refractive patients. And then when we got the series, we were performing these two plus the series. After evaluating hundreds, and we have a very high volume of patients with a very high incidence of keratoconus in the place where I work, we noticed that the Pentacam, combination of Pentacam and Scout, or just the Pentacam itself, was not able to identify many cases that the series was already, the keratoconus screen of the series was already identifying. So for us, the transition mainly happened between the Sirius and the MS39, since we did the change now to performing only Sirius, that's what we were doing since 2014 until 2018, to then stop performing Sirius and just performing the MS39. And we have this corneal refractive practice with a lot of keratoconus patients, and we are very comfortable and confident using this device for evaluating progression of keratoconus and diagnosis of the disease.
Great, thank you, Juan.
Thank you. The next speaker will be Professor Emilio Pedrotti, Strategic Planning in Modern Corneal Graft Surgery with MS39.
Good morning, and thank you for the invitation. Thank you to CSO. May I have the slides? So, this one. So, what we consider modern corneal graft surgery today is a layer-specific surgery because we want to change only the pathological layer of the cornea, letting leave the healthy one with a maximized donor tissue utilization by using the high-performance technology, in specific the OCT and femtosecond laser. So we spoke about SLAC, SALC, and FAMC. What is SLAC? SLAC is a procedure that, that derives from the epikeratofakia that was proposed in the 60s by Professor Baraker, but the new things is another time the femtosecond laser and the OCT. The first modern SLAC was proposed by Professor Mastropasqua in Chieti by creating a pocket in a keratoconus cornea. I insert a negative meniscus shape in order to have a little increase in thickness and creating a flattening on the center of the cornea by mimic the intracorneal ring effect. But we know that keratoconus is a progressive steepening and thinning of cornea. So we try to overcome this problem by inserting a positive meniscus shape in order to fill the gap of ectasia. At the beginning, we planning an ex vivo study. We create a keratoconus model in a host donor cornea by the using of excimer laser. We perform a decentric ablation of 2 diopter in the posterior face of the cornea. Then we create the pocket and we insert our lenticle. It was a very simple procedure, and what we noticed that we have an increase in corneal thickness, obviously, but we have a reduction in maximal posterior elevaton and a flattening of K1 and K2 posteriorly. And you know that keratoconus starting from the posterior face of the cornea. So with this result, we move to human. So we perform a study. We enrolled 60 patients that were in waiting list for adult, and we follow up at 3 and 6, 12 months after the procedure. We customize the lenticle in every patient by measuring the diameters of the lenticle based on instantaneous curval topography by MS39, and we calculate the thickness of the lenticle in order to have postoperatively a total corneal thickness of about 60 microns. And we create the pocket very, very posteriorly, about 10 microns from the endothelium. This is the procedure, is under by topical anesthesia, is very fast. This is the creation of the lenticle. At the end of creation, we mark the center of the lenticle, then we move to the patients. The patient is under the femtosecond laser. We create the pocket. We mark the center of the ectasia. In this case, it was a very centric keratoconus. We open the pocket very easily, obviously, and at the end, we insert the lenticle and we try to put the lenticle in the ectatic area in order to cover the thinning of the keratoconus. And this is a very quick surgery without sutures. At the end, we put a bandage contact lens, and the surgery is finished. This is the result. You can notice that the integration of the lenticles is very clear. The cornea remains clear without fibrosis along 1 year of follow-up. Obviously, we obtain a statistical significant increase in corneal thickness and in the regularity of the pachymetry, and we obtain almost an improvement in all aberrometric index, obviously by means the MS39, and all the patients have a contact lens wearing recovery. All the patients are in waiting list for DALK because they are contact lens intolerance, with a significant improvement in visual acuity using the contact lenses. We check almost for in vivo confocal microscopy, and almost in this case there is a perfect integration of the lenticle in the cornea, but spectacle visual acuity were not very satisfactory because high order aberration remained quite high. So we can study the biomechanical property of the cornea, and we notice that after the lenticle insertion, we have a significant increase in cornea stiffness. So with the help of Professor Vinciquerra and Riccardo, we moved to a transepithelial sequestration customized photorefractive keratectomy in order to reduce high order aberration. This is the result, and what we obtain, a mean spectacle best visual acuity improved of 3 lines. We have a reduction in anterior keratometry, further improvement in high order aberration without any statistical reduction of the pachymetry. We check again the biomechanical property of the cornea, and we note that after SHPTK, the stiffness remained higher than the baseline. SALK. What is SALK? SALK is a sutureless anterior lamellar keratoplasty. The indication is all the pathologies that involve the very anterior part of the cornea. There is several reports in literature that confirm its effectiveness and safety, but what is changing another time, high-tech, by means the multimodal images, high resolution OCT, and by using the femto in order to improve precision, reproducibility, and safety and efficacy. And this is some example of post-infection keratitis. We remove the scar. We can increase the pachymetry also because we can change the thickness of the donor and host lamella. And another time is a beautiful remove the leucoma. This is an interesting case. He's a 55-year-old man that have a retinal detachment surgery in his left eye. He underwent cataract surgery, and it resulted in a ametropia in different refraction in the both eye that created this patient intolerant to spectacle corrections. So we move for a CLEX. After CLEX, we have an important inflammation of the interface with an epithelial ingrowth. We wash the interface. We use YAG laser in order to fix the epithelial ingrowth, but remain a very important interface haze. This is the topography with a poor visual acuity. So we move from a femtosalk. The femtosalk was planning with the aim of MS39. We want to replace the corneal cap, including the A's, and changing with a lamellar graft. And this is the post-operative result. We remove the interfascade. We have an improvement in visual acuity, but without any changes or no significant changes in the topographic topographic partner. Why? Because the sulc behavior is like a flap in the LASIK surgery. At the end, I want to speak about FAMC. FAMC is a femtolaser assisted mushroom keratoplasty. Almost in this case, we set firstly an ex vivo study in order to set our procedure. We understand that the best way is to first create a tunnel to insert the cannula in order to reach the bubble, and then create the mushroom shape. We have a very convinced result. So almost in this case, we move to the human. This is a retrospective study. More or less, this is the strategic shape that we want to create with the femto. We want to have an anterior cap for about 9.1 millimeter in order to have a large graft to maximize refractive outcome, and a posterior part with only 6.1 millimeters. Why this? Because we create a wider area of stromal attachment between donor and host, and in order to if we have to convert the procedure, because we have a break in the central part of the endothelium, we change only a 6 millimeter endothelium in order, and maintaining the benefit of anterior larger graft. This is the procedure, and you can notice that how easily is to find the tunnel, to insert the cannula, injection the air to obtain the bubble. Almost in this case, we study the patients with MS39, and we can detect how nicely host and donor graft junction we have, and this is the result. We study almost 76 patients that have almost 2 years of follow-up. We obtain the mushroom configuration in every case, and the good news is in 87% of the cases we obtain type 1 bubble. So we leave in place the dual layer, and you know that is better. And we have only 80% of perforation, and only 4 cases we have to convert in PK. This is the result, and what we notice that after 1 year, after suture removal, the astigmatism doesn't change. That is confirmed the good option to have a wider area of stromal attachment. Last but not least, we have recurrence keratoconus. Recurrence keratoconus is an inferior corneal thickness associated with increased corneal stiffening following transplant procedures, and affect both PK and ALK about 15 years after the graft surgery. The criteria of diagnosis is not already established, so we follow the global consensus on keratoconus and ectatic disease, and obviously we use MS39 to diagnose it, and what we notice that the ectasia is typically within 1 millimeter of the graft-host junction. Why is crucial to detect this ectasia earlier? Because it's a keratoconus again. So it's a progressive nature. If we don't detect it too early, it leads often to a repeat graft, a larger graft, both DALK or PK. But we know that we have cross-linking that is effective in reduce or halt the progression of the disease. So our study was to investigate the effect of corneal cross-linking in recurrent keratoconus in a long follow-up fashions. So obviously we check tomographic parameter and biomechanical assessment 4 years after cross-linking in this particular subgroup of patients. We therefore demonstrate the progression of the disease and the effectiveness of accelerated cross-linking over the year in stop to fix the problem. This is the result, and we noticed that the year before the cross-linking, there is a progression of the disease, and all during the follow-up of 40 years, there is no progression in the ectatic disorder. And obviously, we increase the biomechanical property of our cornea. Last but not least, MS39 is crucial almost in the endothelial graft surgery. You can follow up the patient by checking the pachymetry. That obviously is reducing over the time, but you can always notice a small detachment that you can't notice at the slit lamp, or almost graft displacement that if you have a very edema cornea is not so easily to detect. So, modern corneal graft surgery is not just an operation, but is a system of precision imaging analytic that covers toward one goal, restoring clear vision in a safe, faster, and more systematic way. And this is made possible by the femtosecond and by using multimodal images that provide objective metrics to personalize the technique and design customized therapeutics procedures. Thank you for your attention.
Thank you for these amazing insights. I have 2 questions, but I will ask the audience first. Do you have questions or comments? Yeah, I'll be loud. So, could you take the microphone?
So when doing this tissue addition, you're creating quite a large pocket. Aren't you afraid of destabilizing the cornea even more? Do you do cross-linking on top to kind of make it stiffer?
No, we don't perform any cross-linking. We noticed that we create the lenticle, maintaining the Bowman layer. We increased the stiffness of the cornea, but only the insertion of the lenticle is enough to increase biomechanical property of the cornea.
Summit.
Thank you for a nice review and the new innovations. How this inlay differ from Xenia inlay? The inlay you put the small lenticle.
Yeah.
Because you put localized at the apex, right? How this different from Xenia, where you put a larger, thinner enforcement of the cornea?
Because the concept it was to fill the ectatic area. So we have the area of the ectasia. So we imagine to fill the gap of this only in this area. So we want to maximize the posterior surface of the cornea. That is not easy with any other techniques, conservative techniques, I mean, and in order to regularize the pachymetry.
So is the aim to improve the regularity of the cornea?
Yes.
Or enforce the cornea? Because like Farhad will probably contribute to that. Putting the Xenia inlay, the idea is you change the whole biomechanics of the cornea as well, rather than focusing on a small area where you know the biomechanics is not just around the apex, is extending way beyond.
Yes. The aim was to increase the biomechanical properties of the cornea, obviously obtaining a regularization of eye order aberration. But when we have a thicker cornea with a more stiffness, we can move with the excimer to regularize the anterior parts.
One question to your calyx case, because you had some epithelium and then you had some intrastromal scarring, and then basically you replaced it, you've done a superficial transplantation. Did you think of converting the cap to flap and to perform an intrastromal PTK?
It could be a procedure. In our case, we have quite experience with sulk that is working very well. The sulk behavior is like a free flap. So I think it could be possible, yes.
I have two questions, Emilio, regarding Slack. What is the minimal thickness that you can safely do Slack in?
So you can perform Slack in very thin cornea. You have a minimum 350 microns of cornea. Yeah, yeah.
And the second question is, if you were to compare Slack plus wavefront-guided PRK later to CARES, where do you see the different indications, types of keratoconus, where you would say, I rather do CARES, I rather do Slack?
Very good questions. We don't have already yet the answer, but I think CARES comes a little bit earlier than Slack.
More advanced cases for Slack?
Yeah, yeah, yeah. In these cases, all the patients were scheduled for dark, so it's a more advanced disease.
What would be the K readings, Kmax readings in a typical Slack case?
I think we have to move about 75, 70 diopters in apex, yeah.
Thank you.
Looking at this, probably the area for graft will be more and more reduced in the future because cross-linking CARES, intrastromal lenticle, endothelial replacement.
We are moving for a more conservative therapeutic strategy for keratoconus. This is absolutely true. Thank you.
Fine. Professor Fradafezzi will present the PACE, how to improve vision with cross-linking.
Thank you, Professor Vinciguerra. So I would like to show you another application where the MS-39 is an essential part of the entire process. ELSA PACE. And PACE stands for PTK-assisted customized epi-on cross-linking. So what we can do in ELSA PACE is we tackle corneas that are way less steep than what you've just seen. The corneas we address are between 50 and 60 diopters. And this is a result of ELSA PACE. And that's just a week or two after. You might say, where is the difference to wavefront-guided PRK? Let me show you a case that we have performed. Looks quite similar, right? The big difference is, in PACE, we do not remove any stroma. This is not an excimer laser effect. It's a cross-linking effect. So it's pure deformation for the benefit of the curvature. To do so, we need three technologies. We need the MS-39 in the first step to do the diagnosis and the planning. Then we need the combination of the Amaris and the CI device to perform PACE. Let me show you how this works. PACE is a development between ELSA, with a lot of input from Francesco Versace, and very interesting also discussions with Shadi Awad and Paolo Vinciguerra during the course of the development. And you can see the demarcation line is mushroom-shaped because depending on where you are in the cornea, you have different penetration depths. Let me just walk you through the concept. The first step is our new epi-on cross-linking. Took us about 6 years to develop, and it finally is in press in the Journal of Refractive Surgery. This is an epi-on that is as strong as the accelerated epi of 10 minutes cross-linking. So a really solid cross-linking. The particularities are you don't need oxygen, you don't need iontophoresis, especially in Italy where I know there is a lot of iontophoresis-assisted epi-on. This one doesn't need it anymore. Took a long time to develop. But if we were only doing this, there would be stability, right? There wouldn't be improvement. But just keep in mind for the next 4 or 5 slides, the more cross-linking, the more flattening. So the idea is, how do we get the most cross-linking over the tip of the cone? Well, in a first step, and we will show you, I will show you, and Francesco later will show you how we plan it in the Phoenix software. We perform a tiny PTK over the Gaussian profile of the anterior surface. And in the Gaussian profile, the keratoconus, a classic cone, looks like an oval-shaped elevation. And the PTK just hugs this elevation. The most common question we get is, I'm a gifted surgeon, I don't need the excimer laser, it's just a PTK, I can do it by hand. You cannot. You will have massive reduction in the effect, 60, 70, 80% less effect. So it's all about concentrating the cross-linking effect on a tiny area and then create a gradient. So imagine we were doing our epi-on that area. It would mean that over the window there is more UV light going in, there is no epithelium blocking. So per definition, if I use the same uniform UV approach, this epi-off area already would have 20% more reaction due to the UV light, if I have enough riboflavin at this position to react. The second is I have way more oxygen availability because there is zero epithelium blocking. Again, the epi-on we developed is decent, but if I use the same irradiation setting, the epi-off would get way more reaction because it has more oxygen availability, more cross-linking, more flattening. So now we have 2 reasons why there is more flattening, but there are 4 reasons in total. The next one is, now I give the riboflavin. What happens is the riboflavin, because of our approach with the penetration enhancers, it goes through the entire cornea. But where there is no epithelium, there's even more. So this area has much more saturation, and the riboflavin goes down into the sides and creates a gradient, a natural gradient, with the most riboflavin over the PTK zone. More riboflavin, more cross-linking, more flattening. That's the 3rd reason. And the last one is we treat in a way where we give even more fluence in the end to the area. So the area gets an additional a few joules per square centimeters of fluence. So in the end you have 4 reasons, and this is why the effect is so massive. That's what you see when you take a still picture. Here is a short video, and you can see decent fluorescence from the whole cornea. That's the epi-on part, and even stronger fluorescence that's obvious from the small zone over the cone. Now the results. That's 4 weeks later. And as you can see, in the central 4 millimeters, the astigmatism has become much more regular. That means better visual quality, better vision with glasses. In some cases, an increase of up to 5-6 lines with a small pupil without sacrificing any tissue. It's a pure cross-linking effect. You can see the difference card. The green is flattening, the red is steepening. And that's the pupillary zone. You can see much more regularity. And that's another example. That's massive. Now, if you look at the difference card here, you will see something amazing. Let's make it bigger. Oops, here. See, that's the difference card. So you have a massive flattening in the lower part, and the upper part comes up. So here, it's a regularization of almost 20 diopters, which means that the coupling effect, the physical effect, if you have a ball and you press inside the ball here, the upper part comes up. The excimer laser doesn't do that. The excimer laser shaves off. So you don't have the coupling effect as strong as you see it here. And this is why we see an age-related dependency. The young patients react massively. The older patients react less because they are stiffer already by age, even in keratoconus. We use PACE a lot now also in asymmetric cataract keratoconus patients, where we say the cornea is asymmetric, let's try to increase symmetry in the cornea first before we address the cataract. What does this mean for aberrations in visual quality? Well, the MS-39 is a really nice tool to show the patient that we understand how the visual perception is before and after. And again, a pure cross-linking effect. Here's another example, before and after. And this is what I used to see with wavefront-guided PRK, but not with cross-linking. So this is really promising. And as I had told you, this is the pachymetry before and after. It's almost identical. Don't forget that when you cross-link, even a normal cross-linking, it compacts the cornea. The packing density of the collagen increases. So you always have you always have a thickness that is 10 to 20 micron less. But that's not real thinning, it's just compacting the collagen fibers. The demarcation line follows. The periphery is our epi-on at roughly 220-30 microns, so a very decent demarcation line depth. And then it goes super deep over the cone. What is interesting is that we have not seen any sign of endothelial decompensation and no massive haze. You will see haze after 6 months and even 12 months. Haze that mimics the PTK zone, because there was up to 15 joules of fluence. But we had very interesting discussions at the last cross-linking meeting, and we had wonderful input from John Marshall, the physicist, who said, when you look at the slit lamp onto the haze, you say, oh yeah, that's not good, it's a lot of haze. But what we see is the forward scatter. What the patient sees is the backward scatter. It's like somebody coming from outside when it's raining with a pair of glasses. You see the person, raindrops on the glasses, and you say, how can you see? And the person says, it's quite okay. I don't need to clean my glasses immediately, because the patient sees the backward scatter. So even in PACE, if you do it, you will always see a certain amount of haze over the PTK area, but it's not relevant to the patient's perception of visual quality. Francesco has created a beta software, ELSA PACE, and what it does, you see here in the lower left, the Gaussian portion. And then we also identify where is the line of sight of the patient and what does the coupling effect do to it. Because depending on how big you make the PTK, you will push the patient towards myopia or hypermetropia, and you don't want to have too much anisometropia. So there's quite a bit of tweaking to it, but basically we try to custom shape the PTK, and the Amaris is, to my knowledge, the only platform that allows you any oval or circular shape of PTK in any offset. And this is what we play with. So we have the offset and the size, shape, and orientation of the PTK we design. And once we have all this, then it's a simple transfer to the PTK module of the OrgCam software. Now, again, one more time. How many of you perform Athens, Cretan protocol, Sterix, Trek? Nobody. Okay, a few. The difference between all these protocols and PACE is that these protocols that have been around for a long time, for now 16, 17 years, they use the excimer laser to perform a reshaping, and then the surgeon will say, oh, I took away 50 micron of tissue, so I need to cross-link to make sure it's stable. So it's a combined effect. PACE is the opposite. PACE is a 100% cross-linking effect. The excimer laser is a tool for the epithelium map-guided PTK where the data come from the MS39. The stroma is unchanged, and you have the additional coupling effect. So in conclusion, we see regularization. Regularization means flattening plus coupling effect. For up to 20 diopters in some cases. We improve CDVA with glasses, 3 lines, 4 lines, sometimes 6 lines. What is not easy is to predict the amount of improvement. We never tell the patient how much they will improve. We all know they always want to hear numbers or percentage. We just say, I haven't seen no improvement yet. There's always an improvement, but the extent and degree is hard to predict for now. You can also use it in stable keratoconus, not only in progressive. And I will show you examples. we can do a wavefront-guided PRK half a year or 1 year later. The effect seems to stabilize after 6 months. We've waited now 1 year for the first PRKs to be done. And here is an example. That's a patient that had PACE, and then later on, total corneal wavefront-guided trans-PRK. So we can bring a patient from 55 to 46 with a much more regular symmetric surface. Where we are standing right now is currently we have roughly 250 eyes treated. The maximal follow-up is 3 full years. The reason we haven't published yet is the availability of the penetration enhancers we need for the cross-linking technology. The regulatory body still is assessing the CE mark since 1.5 years, and we don't want to create too much attention and then not be able to give you the tools at hand. But anybody who has an Amaris, an MS39, the CI, all you need is the penetration enhancers to do epi-on cross-linking and PACE. So we are waiting for that. Should be available in the next few months, hopefully, and then we have a jump start and you can start immediately. I think the Phoenix software is already ready, but this is something that Francesco will show us in a second. We have created for ourselves a pyramid. I've shown it yesterday. So if you have a slightly deformed keratoconus, we suggest using the excimer laser as a fine-tuning tool, very targeted tissue ablation to regularize. If the cornea is more deviated, you have PACE. That's unspecific, no tissue ablation, but deformation. And you can take the patient down. Now, what we have above was what we showed you yesterday. We have femto ICRS, we have femto cares or eco cares, and now I think I should put SLAC on top of it, because it's an approach based on the degree of irregularity. So cares and SLAC would be tissue addition, unspecific effect, and all the way in the very end, we have what you have done, Paolo, in SLAC, right? We have the specific means to correct the aberrations. And this pyramid shouldn't be so clearly defined and demarked because the transitions are very fluent. You can do a PRK in a cornea of 65 diopters if your only aim is to reduce some of the wavefront errors and not tackle any spherical cylindrical error. So that's our ELSA PACE approach. Thank you very much.
Farad, one remarks that when you do a custom ablation, you can aim to get the same regularization. But the point is that you change the anterior surface with the ablation, not the posterior. So sometimes the regularization, I have that terrible experience of the anterior surface, is much worse than not doing nothing, because you have the posterior coma that cannot be corrected by glasses or contact lens, and the patient stable loss his visual acuity. With the PACE, you change both in the same proportion, so you never take the risk to having a beautiful anterior surface, a terrible visual acuity.
It's a nice addition, Paolo. Thank you. And with the MS39, we now do total corneal wavefront with the trans-PRK, so we can even further improve. Yeah. Microphone?
I have one question. On what do you center the PTK? On the thinnest epithelium or on the posterior float, somewhere in between? Because I think this is crucial, the first question.
Yeah.
The second question is, how do you choose the diameter of the PTK? Because I'm playing also with this technique, of course, without the enhancer. And the third question, what is the difference in flattening without using an enhancer, and then if you apply the enhancer? So what is the effect difference?
Yeah, I see where you're going, because these are all very valid questions. The first one is, you will see in a minute when Francesco shows you the beta software, that we took all the minimal points, minimal Kmax, minimal anterior Kmax, minimal anterior pachymetry, and so on. And depending on which center you take, you can slightly shift the center of the PTK zone for the Gaussian profile. And this is what we play with, and now that we finished the study, we asked Francesco to even give us more freedom to tweak the sensor and therefore the ablation zone over the Gaussian profile. But the size is very important, because if you go too close to the line of sight, then if you include the line of sight, you will induce a shift towards hypermetropia. If you are far away, you will go versus myopia. You will elevate the line of sight, so you go versus myopia. And that's a useful tool to make sure the anisometropia to the other eye is not too much. The worst is if you put the PTK edge over the line of sight, then you have a long time in rehabilitation because of the epithelial closure. So we are playing with it, and I think once we have it, we should start some courses of feedback or wet labs or near-life surgery to show the little tweaks. The tweaks are very important because you lose a lot of effect if you shift the parameters.
Okay, Farad, I have two quick questions. The first one, have you looked at the epithelium remodeling, what happened in those areas after? And the second, how can you make it accessible to more of us? Because I don't have Schwind MRS, for example, and I think I'm happy to use a CI, but I don't have the lasers.
The first question is, we are analyzing the remodeling now, and it doesn't show. Let me say it this way. Let me speak about the remodeling as soon as we have all the data ready, which should be in the next 2 months. The second question is, any XML laser system could do it if it would allow you an offset and a certain size PTK. And I think this is just the technical setup, and maybe not on the strategic horizon of other producers, but I think the technology could do it. For now, I don't see a way around the MRIs.
See, I didn't understand how you choose the PTK area.
It's over the Gaussian profile.
Okay.
So it looks quite similar to tangential, but we had long discussions with Francesco in the beginning, which map shall we choose? And according to Francesco, the Gaussian profile is the most realistic representation.
Perfect. And I understand that the riboflavin is different, because if you make face with the normal riboflavin.
We've been working on it for 7 years. So the RiboCare we developed is a riboflavin that is used for all the approaches we have, from epi-on to epi-off to pace. And it has no carriers. It is very, very slightly hyperosmolaric, just to counterbalance the thinning coming from the speculum in epi-off. And it takes 20 minutes to create that gradient. So with the penetration enhancers, it is a decent saturation through the epithelium, but a massive saturation, of course, through the open area. And in the gradient, Victor, that's related to your question, the gradient makes a lot of difference. So if you were to do it without the penetration enhancers, you would have a completely different distribution of flattening. Yeah.
I am asked about the progression and stability of the effect. Sometimes we saw some posterior corneal haze after standard cross-linking, and in those patients, flattening continue to progress.
Yeah.
In your cases, the effect is stable or is progression with the time?
That's an excellent question. We haven't seen so far any continuous progression in these cases. In order to prepare for it, we don't choose 48 diopter corneas. We start at 53, 4, 5, and if it goes down over the center to 48, and it's creeping forward over the next 5, 6 years, it will end up at 43 or 4. So we don't exaggerate the effect, because we cannot totally exclude long-term flattening. But I think a lot of the long-term flattening we saw in the past was due to a combination of a riboflavin and UV settings that modern devices do not show anymore. That's my opinion. Yeah.
Thank you.
Thank you. Now, Samer Ramada, assessing superficial and deep corneal scarring, the role of FM39.
Thank you very much. Thank you, CSO, for invitation. Okay, how we do move this? Do you have a clicker? Oh, there.
This one, the small one here.
That's one, yeah, lovely. Right, okay. What I'm going to share with you some examples how MA39 helped me to making that decision about what type of corneal surgery. We've seen a very beautiful presentation, so a lot of that already presented. I'll just show you some cases, maybe some more pediatric cases. And I think one of the values of having MA39 in my clinic is those children as early, younger as maybe 3, can easily sit for a few seconds, you capture some OCT images, and that's beautiful and help you to do the planning. Sometimes you can even take more information than put them on a slit lamp and do some assessment. And you know corneal scars are not the same, different shape, different location, different depth, different etiology, different pathology. So the question, what you do, what make you decide, what's the decision making process here? So obviously the history sometimes tell you what's going on. So if it's someone with herpetic eye disease, you know that you're going to talk about scar in the anterior stroma. But if something different, you can think of deeper scar. If keratoconus, when they have acute eye drops, you know where they're going to expect the scar. The location of the scar is very important because if I have a scar that is off-center, is not visually significant, then I don't need to worry about doing any surgery. I'm thinking here more different modalities of treatment. The sizing, small scar, large scars, the obsession among us sometimes to clear all the scar is not right because like what Farhad said about haze, same as with some scars. So sometimes I remove as much scar as possible, but it's fine to leave some scar behind. The patient still gets very good visual outcomes. Density, what you look to you sometimes is crazy, hazy, scarred cornea might not be the same for the patient. And you see that especially with the children. You see those with MMP, polysaccharide, corneal metabolic conditions. They got cornea very hazy, very swollen, but the vision is actually great. And if you compare someone with just a little bit of edema from Fuchs dystrophy, you find the vision very compromised. So just think about other things, more just like, okay, I'm going to intervention in surgery. This is the 4 or 5 tools you must have really when you plan your surgery. You need a tomography and the OCT, thanks to CSO, you got one machine give you both, the tomography and the OCT parameters, beautifully high definition. You need to do cell count. And obviously, if you have UBM, it's good for those very scarred cornea where you can't see what happened deep in the cornea or behind the cornea. And B-scan to check, actually, this is a healthy eye. So what potential of vision? Okay, so again, we spend time, and it's not just valuable for me to know what's going on. I share these images with patients. They sit next to me on the screen, and we tell them, okay, this is where the scar, this is what I think I'm going to do. Patients love that. You build that bonding trust in you because you show them what you're talking about. It's not like something imaginative here. Okay, so, and it's not about just, sometimes you have to plan it to think, how thick is the cornea? So pachymetry maps is very important because say you want to do a SALC, for example, superficial anterior lamellar keratoplasty, you want to know what thickness you're talking about. Am I end up doing like a DALC? Am I going deep in the cornea? How much tissue I'm taking the cornea? So the total pachymetry, the variation point to point is important as well. And this is a kind of what's in my mind when I'm talking about a cornea scar, opacity. Does it affect the vision? Does it not? And if it's affecting, where is the opacity? Centrally, periphery, how deep? And that gives me into those various options from just doing PTK, PRK, if the scar is down to 100 micron, or I'm doing more, if it's deeper than that, I might go to SALC down to 250 micron. Deeper than that, you talk about deep anterior lamellar keratoplasty, you can deep in stroma. So that is kind of a broad guidelines, if you like, flow chart here. So I'm not going to bore you with why we're doing superficial keratectomy, you know all that, but it's one of the easiest procedure, very, very effective. Patients love it. The outcome is easy. You can do it in a minimal equipment you need. like those Sosmal type keloid sheet of scarring, which is, as long as it's respecting Bowman's layer, easy to peel. Usually there is no scar behind because Bowman is still intact. Once you start to redo those cases, you're going to find the patient start having scarring. So once you bridge into the stroma, things becoming more kind of difficult to do by just simple superficial keratectomy. PTK, we love doing laser to ablate scar, but we have to accept that actually not necessarily what you plan, what you achieve at the end. The refractive error you induce can be crazy high. Patient might not like it, especially those coming with a small scar, and you tell them, okay, I'll do a little bit of PTK, the cornea will be better, vision better. Actually, they get better, but with the glasses or with the new contact lenses, they not like it because some of them never worn glasses or contact lenses, and now you tell them, I cleared the scar, but I give you a new prescription. So use MMC have to be carefully thought about, especially if you're talking something you worry about risk of haze for various reasons, as you will know. The contact lens test is we keep a set of RGP lenses. It's a must for any patient with some cornea scar. You want to know how much of the vision problem is to do with cornea irregularity and how much actually is the scar. And that's why it's just a simple text, like a couple of minutes, you stick a contact lens and you do over refraction, see how much they improve. If they improve well, I know the scar, no matter how bad, might not be the main thing. I need to work on regularizing the cornea, and then the plan might be changed. Maybe I consider now I'm doing some PRK or PTK therapy. Okay, so this is very similar, actually, what Farhad was talking about, doing kind of a planned, off-center or customized, but this is for the cornea scar. Rohit Shetty group done a great job here doing this centered PTK treatment, very good outcomes. Now, obviously that might induce a lot of irregularities, so they have to be it's not just a bit of laser, it's a bit of art, and think about what the collateral damage you're going to do by treating just very localized area, because you're not talking about, like here, it's paracentral scar on the cornea. But this is a deep scar, 130 micron. They still managed to get 75 micron of that, and the patient achieved a very good outcome, which is obviously great in this case. Now, moving on, the scar is deeper, where you done your MA39, and you know that actually we're talking about deeper scar. I'll show you some examples. This is very simple, and I love it. Like, I think it's, I don't know, my previous colleague said sutureless anterior lamellar keratoplasty. I think this is describe it better than say superficial, because truly it's like sutureless. And patients love it. You're doing cornea graft without suture, like we're doing DMEX. Right, so I work with Shiraz Daya, who's sitting there. So with Shiraz learned a lot about doing those lamellar, try to go lamellar as much as possible, which actually over years I learned it even my way, doing more pediatric work, how lamellar keratoplasty is the way, whether you do anterior or posterior, rather than doing full, etc. And initial, I was assisting those, we done those actually during my fellowship, using a keratome, microkeratome to do SALC and all that, and we have all kind of fun playing with those. Even Marcella, we used to do it together, sitting in the back. But anyway, when femto came, and it was easier to have a precision now, you know, how deep, how the parameter, etc. And the first one we done in Center for Sight, we're using that intralaser. That was amazing experience. Gosh, that must be like, think about it, almost 20 plus years now. But anyway, so it's all learning. But over the years, I don't think, for example, SALC has improved massively more than actually more kind of the lasers improve the precision, etc. So this is the case. Patient, this is not to do with the SALC. This is not talking about various cases, examples. Someone had a pterygium, normal, irritated, peeled off, healed, okay, 6/6 vision. The gun come back after 3 years, and the vision dropped quite badly, actually, 660 from 6/6 before, right? And the cornea looks irregular, and you got all this subepithelial scarring. So something happened, there's some recurrences. So the plan here was to do a little bit of superficial keratectomy to try to regularize the cornea, to try to see if you can take the scar with the laser, but at the same time regularize the cornea, which helped actually, because you can see his topography has quite improved after, like here. And he's got better. That's required taking 80 micron at the quite larger diameter, 8.5 millimeters. So the cornea thin, but he started with a good thick cornea anyway. And things was fine, then came back after a year. There's some more subepithelial thickening here, what's going on? And this guy came, another subepithelial layer scarring. It's like a fibrosis under the cornea. And we start to see more and more cases. And I think some patient, their fibroblast is super active. They develop like keloid type of lesions, subepithelial. So those patients, you have to be very careful when you treat them and manage them, because sometimes you have to do more and more work, as you see here, multi-visits. Definitely there is a recurrence going to happen. We use mitomycin C when we done the last treatment, and was probably okay for a while. I'm sure the patient will come back at some stage, need more treatment. So this is when we treat it, and it stopped here. Now, we said not all scars are the same, and sometimes you have, like here, you got 2 layers of scar. You got that superficial one, which I can probably easily see a clear plane here to clear that superficial scar, which is subepithelial, but also you got deeper scarring. Or you got these cases where you got the scar much deeper, or those keratoconus cases, acute hydros before. How would I decide what to do here? I mean, in the past, you say, okay, you do a PK. I don't want to do PK, I want to do the DALK here. But that's, show me here, might be easy to see on a slit lamp, and you say, okay, look, there is a scarring line. This is like a previous acute hydrops. They have decimate break, so I would not do big bubble technique, which might be right. But I would love to look at the OCT and to see how much, because I might still be able to do big bubble, but sometimes I have to move to something more smarter, like doing pre-decimate lamellar dissection. Okay, so we're gonna skip those. Okay, so let's talk about a couple of pediatric cases, interesting ones. So this is a child with anterior segment dysgenesis anomaly. And look, also they have some loss of corneal sensation from birth. And they develop gradually exposure keratopathy, corneal scarring, and the vision was very bad. As you can see, the right and left eye. And you can see also there's some anterior polar cataract in the right eye. So the child seen somewhere else. The plan was to do full thickness keratoplasty. And I said, hang on, this is a little bit, I don't like to do full PKP in a child of age 4 or 5, because we know the long-term result will not be good. Rejection is high, and it's not fun managing their consequences. Anyhow, so just difference. And you can see there is some element of stem cell problem here as well, whether it's to do with exposure, difficult to tell. But when you done the OCT, MA13, it was very clear to see I still can do DALK for this child. I can preserve the lining of the cornea and give them a better outcome for long-term survival. And that is the right and the left, just various sections. You can see beautifully the anterior polar cataract. Oh, thank you, CSO, for those beautiful images. But it's easy. This child is sat on the slit. She had also some difficult nystagmus eye movement. But we managed to set her on for maybe 10 seconds, and you managed to get this beautiful image. So very quick, very useful tool, I must say. Anyway, so the plan for her, obviously, DALK, and hopefully you're going to do that soon. This is another case a little bit more serious here, because this child, we cannot wait to do a DALK. This child has a brittle cornea syndrome. And unfortunately, in the left eye, the cornea lacerated from minor trauma. So they have a huge cut in the cornea from minor fall. The natural lens gone, so the left eye become aphakic, very poor vision, as you imagine, iris damage, all that. So brought to me, thanks to one of the charities, supported them to come to the UK. And you look at the cornea, it's so ectatic, so thin cornea. Can't remember, but around 200 micron thickness here. So I don't want to do full thickness. Big full PKP gonna be a bit of disaster here, high rejection rate and all that. So my plan is to do like a DALK by taking less tissue if possible. In fact, I did almost epikeratophobia because I just dissected around in the periphery and then try to create a room for the new button, donor button. So I did the peripheral like 1 to 2 millimeter dissection to push the posterior lamellae further inside the eye. And that's why you can see all these wrinkles in the periphery, because that I'm creating a pocket for this cornea graft. And I must say, the child came back, cornea is, I mean, the parents were super amazing, excited that the child can see and could see the 2 lines on the chart. We never done that before. And not only that, this is a cornea that was ectatic, right? Brittle cornea. So now we have a more stronger cornea to tolerate any trauma. Anyhow, this is the right eye. Coming to the left eye, which is much worse. Look at the left eye now, because it's a previous scar, laceration. Believe it or not, they could not stitch it when it happened in his country. So they left it for natural healing. So the cornea actually is healed on itself because they decided the eye is gone. But luckily, it healed and he's still aphakic. So here we go. So we've done some electrodiagnostic testing, make sure that there's good potential of vision. And this is the OCT, the eye before. And you can see here the deep depth of scarring. I tried to do DLK or epikeratosphakia, but it's not working. It's so scarred, so irregular cornea. So I end up doing PK for this child. And this is like a few months after. Beautiful cornea, long-term maintenance is very important here. So those cases can be beautifully managed, but without help of, I know what's my OCT, I won't be able to give him that accurate management plan. And moving now to cases where lamellar is your key. So I don't know how one of you've seen Steven Johnson syndrome patients, especially if those are children, is really, really tough. It's very difficult because you're dealing with stem cell deficiency, you're dealing with the cornea scarring, dealing with poor recovery, poor healing, rejection, all that. So this child, who's known to us for many years, he had the previous grafts, etc., but developed this cornea infiltrate, which is not uncommon in those cases, cornea infiltrate infection. It was not getting better. The cornea started to thin gradually, and then unfortunately is perforated. So the child needed cornea gluing. That's where it was badly infiltrated. Gluing will not last for long. The plan was to do surgery. So what do you do for this child? And you're going to do PKP? Probably not. So I want to do lamellar if I can. So there is a small video here. Let's see if it's going to work. Yes. So I want to get outside the area where there is you can see the perforation there. That's where the glue, so liquid leaks straight away. But I want to do lamellar. So I try to follow a nice plane using heavy viscoelastic to try to get a nice plane, try to preserve the posterior lamellar as much as possible. And not only that, I want to go further in the periphery to allow enough space for the bulky, thick 400, 500 micron donor cornea to sit into that. And it's something you have to do it very slow, very delicate, because you don't want to break decima, you don't want to break the posterior lamellae. Otherwise, it's a conversion to PKP, which is not what I want here. And I don't want this guy will have DSEC, DMEC in future, but at this stage, I want to keep the posterior layer as much as possible. So with just a little bit work, just you can preserve the posterior layer of the cornea. Now, as you can see, he's bleeding. He's a lot of issues here. It's not just about the cornea. There's a 360 degrees vascularization, lumbal stem cell failure total. So I did also stem cell transplantation for this guy. And, but the vessels keep coming back to cornea. So again, long-term ongoing management.
2 more minutes.
2 more minutes, yes. Can we just fast forward the video just for another minute? It's just almost finished, I think. But as you can see, because what I saw you here, the message here, yeah, just run to just before the end a little bit, if that's okay. Just peeling from the donor, taking off the sime. Okay. Fine. The message on this one, they have a double AC, right? Because they have a perforated cornea. So I know they will have double AC. I was not surprised. But I know that it's going to heal with time. And I've done it these times, and always, touch wood, proven right. So initially, they will have double AC. The vision will be reduced, and patients will still complain. And fellows come say, oh, Mr. Hamada, look, the double AC is not working. Shall we do bubbling? I don't put bubbles in the eyes with those cases. They're not going to reposition. It's not going to work. I just leave for natural healing. And actually, it's you can see this child. Look at his cornea. It's fully attached now. There's no double AC, and the vision improved, and we'll give him a clarity. So, and the story again and again, and this is the other guy. Same story. You see the double AC. This is after I did a DALK for this guy. Same story. Full thickness was perforation, and then I did a DALK, and afterwards, took longer. This one, I think, got 3 months until, but sealed eventually. And you can see here that's at some place where there's a decimal broken, but it's attached itself as time. So it's just a time is essence in those cases. Just have to. I have 1 minute. Maybe I should show you 1 or 2 some more quick cases. This is a guy. He's a came with a corneal scar. Again, he was listed for DALK, and he came to me. He said, long waiting list NHS, can I have something simple? And I looked at it, I said, I can do SALK for this guy. Why not sutureless, again, lamellar keratoplasty? So he's another one who doesn't need a DALK, even though he was on the list for a DALK. He will need a SALK, basically. Okay, and just we talked about, okay, good. The last one, Aniridia, and I put this because I want to show you what looks sometimes horrible scarred cornea. Actually, it is just epithelium and subepithelial scarring. Look at this here. Actually, the stroma is nicely clear. So this patient just needs a stem transplantation, which we did, and you see her epithelium before and after. She got much better results. So I think that's it. I didn't manage to do my slides. Thank you very much. Good.
Very much, Summer. Are there questions from the audience, comments to the cases?
I think with the other talks, we covered this very nicely. Yeah. OCT help you in guiding cornea management, cornea scar management. Yeah.
We are a little bit in delay, so
Thank you very much.
Ask to Ivan Gabric, role of anterior segment OCT in decision making and complication management of refractive and therapeutic surgeries.
Okay. I promise to be quick because the next thing is the coffee break, okay? But before we start, how many of you still don't use anterior segment OCT as your baseline device? Please. How many? Okay, you're a liar. Okay, so I always like this picture because it shows blind people touching an elephant, and they're all touching different body parts, and they all are very correct, but none of them see the whole picture because none of them see that it is an elephant. And this comes with this. When you allow your technician to take that scan and bring you a printout, you have destined yourself to the lowest denominator. That's your technician's ability to see what's important for you and to bring you that piece of paper. Have a workstation like our colleague from Cairo showed in your office. Slide through the pictures. That's why modern diagnostics is there. Because if you allow your tech to bring you a piece of paper, you might be missing out and getting this. Okay? No button pushing. These slides are from Warren Hill. He's a smart man. Trust him if you don't trust me. So, I still hear people saying, oh, I still do this regularly for my cataract cases. They're liars. People who rely only on placebo rely on the quality of the tear film and on the gods of Egypt, because these are very variable. You need information. But then we have people who rely on this. And many people before me showed you today that Scheinflug as a technology, it's run its course. Unfortunately, it's gave what it could, but any scarring, any issues, you will have a problem. But the biggest problem for relying on Scheinflug for anything except basic visualization is the time delay. It takes 2 seconds to capture the cornea, so you can have motion artifacting. You can have many issues, including gaze area, and you could lose the important data that you have. And also, the biggest issue in my mind is what's between the slices. The Pentacam standardly does 25 slices. In the high-resolution mode, it does 50. But that still just covers 1 degree, then skips 3 degrees or 6, depending on the scan type. So what's between the lines? It's the Oculus software, which is really good. It's really good, but it's interpreted data. Then you have the devices like Sirius and Galilei, which combine Placido, so instant topography, with Scheinflug, which is better than pure Scheinflug because you do get that instant snapshot. But then again, they still require dark rooms, patients under a hood. I mean, they're not going to get killed, right? It looks like when you're going to the guillotine, they put that hood over your head and take you into the room. I hate that. Then you have the Anterion, which in my opinion is a great device with one basic problem. And that problem is these little LEDs here. The Anterion does 60 slices, 64, very quickly, but it still has this motion artifacting that in some cases can lead to approximations which are not, in some cases, clinically relevant, but they say this is good enough to do refractive surgery, but then they use the LEDs for the calculation of keratometry values for cataract surgery. That's how much they trust their scanner. And then we have the MS39, and I love it. We all love it. I'm not going to tell you why I love it. I'm going to show you how I use it. And we have Cassia, good idea, but still lacks the Placido. So this is the same eye in Scheinflug in perfect conditions and in anterior segment OCT. This is the only image that distributors need to show doctors and doctors need to show patients why they've switched from Pentacam. I still routinely get patients asking me, can I perform a Pentacam scan on them? I say I can, but I won't. They ask me why. I sit down and I show them this picture. I say, which scan do you want to have? It's quite quickly decided. I showed this last year, so who saw it, sorry. This patient was followed up for keratoconus by a doctor who never looked at the Scheinflug images because he could have seen it here. He was just given these printouts and was telling this patient, hey, you're doing fine, your keratoconus is not progressing, continue wearing those rigid gas permeable lenses, you're gonna have good vision for the rest of your life. He's not. The Scheinflug image was showing this, but because the doctor was just getting the printout and the technician was just clicking print list, nobody noticed that this man has 100 microns of stroma left and that everything above that is just a loose bit of epithelium which is being rubbed on by that rigid gas permeable lens. This patient is, I don't want him to sneeze or when he's going to the toilet to squish too much because that could really end badly for him, okay? Oh yeah, that's his other eye, it's in the same shape. So thank you, Scheinflug. This is why Oculus wins, it's the colors. My father still, after having MS39 for years and the series for 10 plus years, he says, I like those colors. So Francesco, please, I know these are not standard colors, but people like these colors for some reason. Everyone knows how to read them. And the way they teach you is, okay, red over blue, safe. Blue over red, not safe. And this is people do it like that. They don't look at the numbers, they look at colors, and that's how they remember topography. It's wrong, but that's what we live with. This is the same eye on MS39. It doesn't look the same. That's the problem. If you go from knowing how to read this, going to this takes a little bit of adjustment. And you know what? Doctors are creatures of habits. They're very, very, very opinionated, and they don't want to change, ever, for anyone. So this is a patient that had an aborted lenticule cut, and we wanted to see what's going on. Can you imagine trying to shine Scheinflug into this? You would just get a big white return. But here, we saw the gas that separated part of the lenticule, we saw where the lenticule ended, and we could plan a recovery case. If we did not have ASOCT, now this is not unique to MS39, it's just the one that I like, you can make a plan. You can then compare his cornea to pre and post the next day. You can then do many other magical things. Here, when you do the high resolution scan, you can check for flap integrity or lenticule depth. You can actually see how the flap was cut irregularly. Those things are unavailable in Scheinflug-based devices. So this, let's say you have to retreat a patient who's had LASIK 20 years ago in a different continent. Without ASOCT, you don't know where you're going. You are going to find out if that flap has a hole during surgery. What if you leave something in the pocket of a lenticule, like a little piece of epithelium? Here. Well, you can show it to the patient. You can say, hey, this is just epithelium. I am going to remove it. Once you remove it, you can print this beautiful difference map for him to show what you removed and why he doesn't have a problem anymore. Can you do that with Scheinflug? Yes, you can get these maps, but you can't show it to the patient like this. Hey, this is you, epi in, this is you, epi out. And you give this to the patient. And you can also use this for surgical planning, because I see the bump here. Okay, this is the cut, and when I go to my OR, in my head, or I can even print this picture, I can plan where to enter. Because you know what's very difficult to see under a microscope? Loose epithelium. Sometimes when it's still not whitish, it takes a little bit of effort to find it, but with this, you know exactly where to pick it up. This is the same idea. This is Osiris detecting a few epithelial cells 24 hours after surgery. And you can already see that even this tiny amount of epithelium is causing a diffraction there. And this patient will notice this by saying, oh, there is something in the corner of my eye like making a light streak. Without the applanation-like view on MS-39, which is a unique feature, thank you, Francesco, but you need to teach people what it takes as a reference body. There's a big discussion there. But here, this is it. Can you imagine seeing this without ASOCT? Even in the normal view, you won't see it. But then once you remove it and you keep the applanation-like view, and now the reference body became the BCL on top, you can see how the sagging of the epithelium here, which modified itself in less than 24 hours, is seen. Yes, it's going to grow back in a few hours, but this image, again, you print this off and you show your patient, here, I fixed it. This is not available with Scheinflug. So, what happens, and Victor told us yesterday, he had this, sometimes when you're dissecting a lenticule, you think you're up, but you're down, and then you start chopping around and looking for the top, and you're 100% certain you're right. But then after 2 minutes, you decide, no, I'm going to lift my patient, take him to the diagnostic area, take an MS-39, and see that, no, I did not touch the top plane. And then, if you're very smart, you have this on board, and you recover your case, and you don't have a complication. Because if you don't have this device, you will end up like this. This was shared to me by a friend of ours who spent an hour trying to dissect a lenticule. He thought he dissected the top plane and then kept dissecting and ended up putting a lot of epithelium, a lot of meibomian glands, excretions, created a cornea which is not in a good shape, but you can see the top. He never touched it. He called me after doing these cuts and said, hey, what's my next step? Stop. That's the only next step you can do. This is how this cornea looked after 1 week. You can see clearly that he created another completely separate plane with a communication here to the bottom, but the top cut he never opened. If he didn't have intra-op availability of MS-39 and continued, he would have broken this cornea. And this would have been a scar on his career and for the patient for the rest of her life. The three scariest letters in my life are CTK. In the past 27 years, we've been doing refractive surgery on the cornea. 7 patients ended up having a PK. Going back and looking at their data, 6 of them were unrecognized central toxic keratopathy. In the age of OCT, seeing this funnel shape next day or in the first week is the only way to know it's CTK. The depression, the hyperopic shift, you can account for many different things, but with an OCT, you can see that this is CTK. And if you don't stop steroids, you will end up with a big problem. On a slit lamp exam, CTK can look like DLK. And most CTK does develop from DLK at some point, but treating DLK needs steroids and treating CTK doesn't need steroids. Because if you continue giving steroids, you're going to get this. This is scary because once the cornea compacts, it's like you've done cross-linking on it. Horrible outcomes. Here, This is my patient. She knows I use her name. She's cool with it. This is 7 days after lenticle extraction. You can see a clear change in the refractive power. This is the scan. You can see here that everything is inflamed. You can even see where the lenticle is, and all of this now is compacted. So please, if they're losing vision, just think it could be CTK. Now, how would you plan a case like this if you did not have access to OCT? Probably impossible. Why? The guy's a doctor, an orthopedic surgeon, so not the brightest. We know they're not amongst the smartest doctors, but still a doctor. Yes, it's true. They go to the gym, they're very strong. Anyways, he was told by many doctors that the only way is a PK because look at the size of your scar. It's massive, really, really a massive scar. Imagine imaging this on Scheinflug. This would just give you a huge reflection. And then imagine doing this with a keratoscopy device. You would just have squiggly lines. But using OCT, we actually made a plan. And using the MS-39, it ended up actually generating a map, which was then loaded into Amaris. And this is what I told him. Look, your gradient, the number of diopters of change is in the 3 millimeters of your pupil, 6 diopters per millimeter. It's a huge change. There's no contact lens on the planet that can fix that. Even on retroillumination, you can see the scar and the depression causing the light to bend. It was great. So this was the plan. It was exported from MS-39 into Amaris. He was not a good fixator, but 54 seconds later, he ends up with +3, -4, no issues. The irregularity was reduced to 1 diopter per millimeter. And this is the side-by-side difference map. Huge difference. And now for a magic trick. His cornea got 100 microns over the area where it was the thinnest. The epithelium doesn't like going up and down, but it likes to smooth itself over. So by lowering the other side and not really touching the scar at all, he ended up with the cornea having a normal shape, a smoother shape, and having better vision. And at the end of the day, what do you use when you want to do something? So this is my father's eye. He had oblique astigmatism, treated with a wavelight laser in 2006. The opticals was pretty nice. Aberrations were pretty nice. And we had a discussion. Can he get a premium IOL or not? All of my colleagues and all of my friends who use Pentacam said, no, look, the colors are off. But I trusted Osiris. I trusted, at that time, Sirius. We did the calculation for his lens using the ray trace method from our friend there. It's pretty good. And here's his eye later. See, we put in a symphony. Pretty happy with it. Kept doing surgery. Kept seeing and driving. So, that's it. You can have coffee now.
I have one question, because
Okay.
you show in the last cases that opacity is much less important than regularities.
Just regularity. And this is what you said. Forward scatter versus back scatter. It changes the perception in your head, and this is why Scheinflug is so dangerous, because it gives that reflection and you're thinking, oh my God, that person's blind.
And in that case of the massive coma you had, you only tackled the higher order aberration.
Just the higher orders. Nothing with the scar. Just the regularization to the other side.
Nice.
Thank you.
time, right, Marko? I'd like to welcome Marko Haulina from Slovenia, who's going to speak about the role of electrophysiology in objective assessment of visual function. Don't go to sleep. It's an interesting talk.
I'll try to not keep you really too bored with this subject, which is totally different aspect and totally different area of what it was said before. I'm speaking here on behalf of CSO and on request of Claudio Baglini, who is the author of this machinery. And I'd like to greet you from Ljubljana when I run I'm the head of neuro-ophthalmology and retinal dystrophy service, but I also do a lot of premium lenses. So everything here, what was said, is very useful to me. This is the new hospital that we moved in 2000, and this top floor here, we are quite proud on this because this is a new center for visually impaired and blind, which houses all services like sociologists, psychologists, tiflopedagogues on one place, and that's quite a nice achievement in Slovenia, financed partly by the European Union. So going back to electrophysiology now, you all remember this retinal diagram. What I'll be talking about is these electrophysiology responses, which are like, let's say, signature of each of the cells. So cones will give you a sharp signal, and rod will give you a slow signal under the dark adaptation, and then we will have a mixed response when you dark adapt the patient and shine a very bright light on the retina, and then you can use 30 Hz flicker, which is flickering very fast, which is very useful also for, let's say, corneal opacities, if you want to establish the function of the retina. And then you have PET NIAG, which is specific for the ganglion cell response, which is quite useful for diagnosis of optic neuropathies, starting with glaucoma, optic neuritis, Leber hereditary optic neuropathy. And then you have multifocal EIG, which is actually a cone response, but it is topographically organized. So it's like an electrophysiological visual field in a way. And then we have visual evoked potentials to tell you, if the information from the retina has reached the visual cortex. In the past, we used this funny invasive contact lens electrodes, which were quite invasive, and then we in Ljubljana developed this type of electrodes, which is widely used as well as with the CSO. And this electrode really is non-invasive. You can put a drop of local anesthetic, just actually stick it under the lower lid. And this is actually an insulated wire which has 3 contact windows in contact with the bulbar conjunctiva. And then you can get all types of EIG responses with this electrode without actually causing too much trouble to the patient. And this is, for example, multifocal EIG, which shows this specific central peak in the center where the density of the cones is the biggest. And it will show you very clearly if there is something wrong with the macula, this will not be as sharp. So ICEV has standardized, ICEV is International Society of Clinical Electrophysiology for Vision, has standardized these 5 responses, and also standardized PET NIAG, which has 2 peaks like P50, which tells you macular function, and N95, which is interesting because it tells you early changes in the optic nerve dysfunction. And then VEP, as I said, will tell you whether the time needed from the retina to the visual cortex is prolonged and whether the signal has reached the amplitude that you're expecting. It's approximately 100 milliseconds to travel to the cortex. Right, so one nice thing about multifocal EIG is that it does not actually have any information of the ganglion cells and no information about the optic nerve, so it clearly tells you whether the problem lies in photoreceptors. So this is very useful because you can discern very clearly between the macular dysfunction or optic nerve dysfunction. I'll show this later on. And for flash ERG, it is characteristic that this is a mass response, and it shows generalized photoreceptor dysfunctions, but not necessarily macular dysfunction, because macula is such a small area in the retinal surface. So maculopathies are, as I said, better shown by multifocal ERG, and this is one example in Stargardt's disease, where you have central scotoma, and flash ERGs would be normal, and you clearly see this missing peak here in the center, which is actually, showing the lack of the macular responses. If you have a patient on chloroquine for a while, then you can actually follow multifocal ERGs, and it will typically show this paracentral dysfunction, which you see here also in OCT as layers which are poorly formed. And this some people describe as a flying saucer sign in, chloroquine retinopathy. So from this you can actually put up such a map that will tell you where the problem is, and actually it's quite useful to know that we can actually discern pretty well between different layers in the retina. Okay, why would we still use electrophysiology in the time of OCT and then autofluorescence imaging? Well, basically we need a functional responses, right? So especially in children, where you have non-verbal children, it's very important to discern between congenital idiopathic nystagmus or associated retinal optic nerve disease or retinal disease, and you can actually clearly do so. Is visual function loss organic? Are early changes in function actually something that OCT does not show up as yet, but it may later? So it can precede OCT changes. So is it, as I said, retina or optic nerve problem? Is it progressive or stationary? Or is there any objective improvement over time? Because many times we have psychophysical methods. Patients will actually be tempted to see better, but do they really see better? We can see this objectively. For children with congenital labor congenital amaurosis, or LCA, this is very important methodology which shows that early, actually after birth, you will have lost all the ERG responses. That's very sad diagnosis to make. Very rare, luckily. And if we have medically unexplained visual loss, then we actually may be asking ourselves, is there no organic disease? Are disease signs not yet detected? Or are they some psychoorganic conditions, malingering? Or are they not properly screened? And don't forget about keratoconus, because this is many times a year sent to our clinic with query unknown loss of vision. However, it's early keratoconus, can be seen very clearly on either topography or MS39. Right, so in medically unexplained visual loss, basically, what you are usually thinking when you have a patient coming to your office, what kind of patient are you dealing with? And in medically unexplained visual loss, approximately 70 to 80% are female, according to literature, and approximately 70% are bilateral. Approximately 80% will have concentric visual loss, and approximately 60% will complain of glare and pain. Central scotoma would be quite rare, and very few will turn out to be organic, really, but what if they are organic? So you cannot really send patient away if you're not quite sure. So this is an example of 35 years old lady that had surgery of ovary carcinoma, and she explained to us later on after the surgery that she has worse vision in darkness. She had normal visual acuity and normal full color vision. OCT and autofluorescence was normal. So is it psychoorganic? No, it's not. You see clearly that rod responses are missing, that you have this negative type of response, so B wave is lower, and we are losing dark adapted oscillatory potentials while the cone function is still pretty normal. So this is suggesting paraneoplastic retinopathy in this lady. So you don't want to send such patients home with query malingering. Right, so the next case is 61 years old gentleman that said has light, some lights are shimmering, and he had 0.4 vision in both eyes. OCT was normal. And what did he have? He had, again, negative type of ERG, again, rod response missing, and also he had this kind of on response in the on-off response, so on bipolars are not working. And that's quite typical signature for melanoma-associated retinopathy, and he had cutaneous melanoma with metastasis showing on ERG earlier than presented with his disease. So this is a case with 37 years old lady that came over to tell us that she doesn't see both eyes, which is quite interesting. And on 30-degree field, she didn't have any central scotoma. On 10-degree field, she did show some central scotoma. She did show some lesions of demyelinating nature in the brain, but not very specific. But what you see here is that she has clear loss of N95, which should go all the way down here, and she had prolonged VEPs in both eyes. And multifocal ERG is perfectly normal, so it's not maculopathy, this is optic neuropathy, both eyes affecting both eyes, and she had demyelinating optic neuropathy. Here are at least two gentlemen here who operate cataract and do know a lot about Leber hereditary optic neuropathy, Giacomo Savini, and we in the group of let's say very large group of scientists in Bologna. They actually study Leber hereditary optic neuropathy for many years with the group of Valerio Carelli. This disease is specifically actually dealing with optic nerve problem, but the problem starts with ganglion cells. And ganglion cells are actually those which are primarily affected in this disease. And if we do genetic testing early, we may find out this disease, but however, not always, because sometimes you may have 3 mutations which are actually negative. And then you may think it's probably not of the Leber hereditary optic neuropathy. Now, this was a gentleman that had this typical presentation of hyperemic disc without leakage and had this N95 loss in early stages. And actually, he was found to have atypical mutation, which was published, and it's very, very similar to the mutation that was also published by the group of Valerio Carelli. So one thing which is interesting with Leber hereditary optic neuropathy, maybe for you to know, is that it was always thought to be mitochondrial disease, but it's recently found that it could also be transmitted with recessive type of mutation. And we had 2 such patients that were quite typical for Leber's. Again, N95 wave missing, and again, P100 wave prolonged and reduced. And that was quite typical, and for his progression, we saw this kind of loss of vision over time. However, he was actually lucky that over time his vision started to improve, and over time it improved quite well. And this disease actually, when it's transmitted in a recessive fashion, has better prognosis than mitochondrial diseases. We published these 2 cases, and you can see this progression of improvement on these slides here. Now to go to Retimax. Retimax is a system that is shown here in the exhibition room, It's been a creation of Claudio Baglini, more or less over the years. And it has all these features that we described. And Retimax has also a handheld system for children, and also has miniguns filled for, again, for children and those which cannot be moved. And then it is standardized with HK loop electrodes, so that you don't need to do your own standards. You can do VEP responses and see all this, what I described very nicely. And it says that it will also tell you that where the system actually tells you where you are in the normal values or over the normal values. And this also has multifocal ERG, and you can project this onto the retina, on the retinal image, or you can actually also put it on widescreen, different types of the cameras or visual fields. So you can project visual information, the functional information on the images. And we also treated these patients, actually used this machine for training of vision, which is also a feature of this system. You can train patients that can actually, in repetitive training through like that 10 sessions, develop better vision over time. We did that in amblyopia after the critical period, and this study actually showed that these amblyopic children after critical period had better contrast sensitivity and gained about 3 lines, or let's say up to 3 lines of visual acuity. It can also be used for dark adoptometry, and it's very, very useful for vitamin A deficiency. This is one case that showed this loss of ERGs over time, and then after substitution of treatment, the responses came back. We are, just to conclude, getting into the era of gene therapy, and gene therapy will actually hopefully offer us new modalities of treatment of these diseases over time, and you need to objectively follow that up with electrophysiology, but sometimes responses in late stages are too low actually to be recorded. So that's why you need full field stimulus test, FST, which is also possible to be done in this machine. So to conclude, electrophysiology is an indispensable tool for functional diagnosis, especially in children in unexplained visual loss. It gives you objective visual acuity test, gives you follow-up testing. Clinical studies cannot be done without it, and combination with FST and adoptometry will be used for the late cases of genetic diseases. And Retimax really has it all. Thank you very much on behalf of our team.
So, now Marco, tell me, who comes up with this terminology, multifocal? I mean, I know what multifocal is. That's not multifocal. That's multi-positional ERG, right?
Yeah. It's multifocal. It tells you multifocality will not be any type of optic multifocality. It's been chosen because it actually gives you information from different aspects of the retina in different times. And each of these patterns from the retina will go in different directory of the machine. So you will get this.
I accept that. But surely it's multi-positional.
Yeah, it could be multi-position, yes.
You need to go back to your society and tell them you're confusing simpletons like me.
Yeah.
Anybody have any questions? Great.
Yeah.
I think we can move on. Thank you very much. I got an education there.
Thank you.
Yeah, very useful exercise in ERG. The next speaker is Samir Hamada, who's going to entertain us too. On dry eye. God, they left the best of the last, huh? Dry assessment with what? Antares. With Antares, according to Dues 3.
Thank you.
Great, thank you. Welcome, Samir.
Thank you.
No, yours down there.
There we go, that's better. Right, thank you again for the invitation. Thank you, CSO, also arranging a nice meeting in beautiful Florence today, which is great. So I'm going to tell you a little bit about what Use 3 offered to us in terms of understanding and using our diagnostics. Before that, let's go back to medical school, learn a little bit about the histopathology here. And I'm trying to make it very simple, but just to understand how the meibomian glands is formed and what make it blocked. So if you look top right, you can see that the gland here is blocked because you got multi-layers of keratin blocking the glands. The gland normally, at the end, is surrounded by rheolin muscles. This is help the last bit of the meibum to be expressed from the glands. And when you understand this, you understand how it works, because you've got here, let's magnify that. So you've got the stem cells here, a layer of cells here, produces basal cells, start to differentiate, start to get nucleus, and then they're becoming the meibocytes. Meibocyte is the one that is, you remember, is holocrine gland. So the meibocyte explode and release all the meibium into that ductile, which lead to the central ductile out of the eye. So this is how the meibium is produced. So if you think about it, you know now we have stem cells for meibomian glands. We know how it functions. We know how is the problem. But that's morphology. Sorry, histology. When we look at what we learn from histology, it's interesting. It's told you when they correlate what they can see under the microscope and the function, they tell you those glands you see in mammography that are hooked, tortuous, overlapped are actually normal glands, which is a little interesting because that's not what we think when we look at mammography. But they correlate that the length of the gland is very important. Full-length gland is good. Short glands is not good. And when you don't see a gland on mammography, that means there's no gland, it's atrophied, which is good. So what Use 3 told us? I mean, a lot of things we know already, but make it more clear based on the evidence, the reviews, and all that. Tells you questionnaire is important. OSDI, 6 short questionnaire, really helpful. Then emphasize on non-invasive tea break-up time and the mammography. Those are 2 keys, and that's why, for example, Antares helped me in that, getting those 2 elements very easy. And when you talk about the glands, it told you 2 things. It's the morphology of the glands, but also expressibility. What type of meibum you're getting, it's a quality of meibum. So there's 2 different elements. You might have amazing glands, looking good, but actually the function is not good. The meibum is bad. And then featured on the glands itself, it's about what they look like. Are they long, tortuous? Are they truncated? Are they short? Many other features we're going to cover a little bit later on. So as I said, the Antares covered that because you get the meibography, very nice image resolution. You can measure non-invasive break-up time. You can do meniscus height, which is very helpful. And more important, you can show your patient what you can see. And that's a powerful tool in diagnosis, in communicate your information to patients and get compliance. This is really, really useful tool, and patients love it to look at the image of their scan, and that helps compliance with the treatment for sure. Okay, so let's look at what quantitative, qualitative analysis of meibomian gland, what we can see and what is it here. So let's focus first on the structure of the glands. So as you know, MGD dysfunction, meibomian gland dysfunction is the #1 cause of a dry eye. Fine, but there's a lot of times there is a mismatch between what you see, what the actual. So you might have a patient have a normally healthy ocular surface measuring tear break-up time, but they have abnormal glands. Same as patient coming for cataract surgery, they have no symptoms, but they have signs. Those are dangerous case because those can become a symptomatic patient that can have a problem with the ocular surface after surgery. And the same thing here, when you look at the eye, patient have no symptoms, and the eye looks might be fine, but you do mammography and you find the glands are not healthy. That's actually a warning sign that this patient might turn up into a patient who had a really severe dry eye and continue their suffering. So, and the other advantage of the mammography that is non-invasive. Really, the resolution is great now. We have a lot of information. But the question, are the information we're getting matching how we interpret them and how we implement them in our clinical practice? I don't think so. I think we're getting beautiful images of the glands, but so far all we do is that what? Show the images, okay, yeah, there's some glands missing. We measure the volume on the area which is there is a gland which is missing, and that's how we conclude our management. I think there's more to that. So our interpretation is deficient at the moment. we could do more with the images we get. So technology advanced, but I don't think we match it from a clinical side. And this is important. The dropout, it is not enough to say the gland is not working or is there a big disease here. There is some more things you have to look at, like the shape of the glands, the density, tortuosity, some other specific features. Right, so for example, ghosted glands and dropout of glands, which is worse? To lose glands, you can't see them, or the glands there, but they are ghost, they are like very thin and almost gone. Which is more serious, right? There's some changes, tortuosity of the gland, it happens with age. So there is age-related meibomian gland changes as well. So it's often missed with meibomian gland dysfunction. So these sort of things, you have to see it and then correlate it with your clinical signs and symptoms to come up with beautiful diagnosis, you know what actually matters in my clinical diagnosis here, in my management. And that guides your management quite lovely along the way. Because the last thing you want to do is that something you see turn into irreversible disease, irreversible atrophy of the glands, and that's going to be more challenging to manage and control. So there is a lot of nice studies show you how accurate is Antares in comparing the mammography, give you the imaging, correlate that, non-invasive break-up time with the invasive break-up time. So it's very reliable. So you know that you have a machine that actually delivers what's promised to deliver in high accuracy. The grading system, however, a lot of devices use that old grading system, which I think we need to move on from, because it's looking at general area of the gland loss, which is not really necessarily tells you, because those give you figures, but I can tell you that 78% or 76% on the bottom right might not be the worst case of all those, right? So these things we have to be careful about reading it. You have to think about, right, what the glands look like. There's so many shapes, it will come with all different names or it, but you know that the glands are short, around a good length, thin, fluffy, and getting fat, very high intensity and fatty glands, short and how short, or truncated. So all this means something. And I don't want to bore you here, but I just tell you a couple of things here. When you see tortuous gland, be careful. This could be an early sign of a disease. The ghosted glands, a very thin one, tell you it's a severe disease already. Truncated glands tell you already the disease is gone bad. You need to act quickly. That tells me that this patient, I have to really move on quickly with management plan. I have to put a strategy to stop further deterioration. Because the one thing we all know that if you lost the gland, they don't come back until the day where we know that how to do stem cell transplantation for those glands to regenerate them. Okay, couple of things. Central dropout, you could notice, you see those your patient, if there is a central dropout, usually inflammatory. If you see on the edges more periphery, that's more usually mechanical because the orbicularis is not as strong in the side. So small things, but it means something in the terms of management, and you plan your treatment onwards. And as I said, symptoms don't match signs a lot of times, so you have to be careful that to know where is the correlation and help yourself by combining this with other clinical tests that's available to us. So this is just a simple example, and this is not like a guideline, but a rough idea where you go with. If you got a little bit of mild tortuosity, then probably you go with the lid hygiene, some blinking rehabilitation. If it's more to that, you think about, okay, maybe I need to do IPL. If it's really quite a lot of dropout, you know this ocular surface is severely inflamed and endangered. You might have to go up the game, more treatment, serum eye drops, and something else to try to see if we can make the gland survive more and carry on. Okay, so again, if you look at meibography as well, sometimes you have to repeat it, you have to treat the ocular surface. Top case here, you can see this patient have a lot of papillary reaction. That blur the image, so you're not going to get accurate measure. Sometimes you can't even see the glands properly. So you have to treat those patient first, and then bring him back, maybe repeat meibography. And just the cases here, you can hit, this is like, this is still a mild case. You can see the glands actually, length is good. They're quite fatty glands on the bottom eyelid, but they're good. There is a bit loss nasally here. So this patient might need a minimal line of treatment. Top eyelid is more a problem, you can see here. Think about, do they need more than just lid hygiene? Do they need blink exercises, needs more supplement, etc.? This is more severe when you see the glands start truncated. That tells you the disease is getting into moderate to severe. Here is the disease progressively got worse and worse and worse to get gland become absent, atrophy. Those patients need a bit more management. So this is just a guidance, and in your practice, what you can offer patient, you can decide what actually works for those patients, depends on the case from mild to severe. The things you have to look deeper now, we start to read more into it, say, right, okay, the grading we said is traditional grading is not a grade, but there are subtle markers, and those are the main ones are the tortuosity, the ghost glands, and something to do with signal intensity. So for example, this is called signal intensity. If the signal is weakened from the gland, that means the gland look fainted, that actually could be the glands before become atrophied and lost. If the gland is so bright, the signal is strong, that tells you the gland is actually probably obstructed, right? There's a buildup in mucus inside the gland. And that can guide you what treatment to do. There's something about tortuosity index as well. So, as I said, with age, things change. So by less than 25% tortuosity is fine. More than that is a disease. And when you see the gland start to look wiggly, that's early signs of you need to act quickly. Forget about a bit of drops and a bit of massage. It's not going to work. So the warning sign, you see it in some patterns. And again, there's a studies need to go deeper into that to really have a good correlation. But also things when you see on the top eyelid, because let me tell you, top eyelid is very important. If you see that the disease only affecting the top eyelid, not the bottom eyelid, ask yourself, why? Am I missing something here? If it's just one eyelid, not the other eyelids, why? Could be something to do with lymphoproliferatic. So it could be talking about here a cancer. This is how it can be. You need to look really carefully at it. But most autoimmune diseases start with the top eyelid. Surprise. Okay, so we covered that. The other thing, which is not Antares now, we talk about the epithelium. Remember, the epithelium can get thicker, and on the long term of dry eye, get thinner. So this is a nice case by Miftahi group. What they did, they look at this patient with, look at the inferior, look at epithelium map, inferior thickening here, right? And this eye had more drop out of the glands. While this eye is better, so this thickening is happening less here. With the treatment, it gets better. But when it starts to get generalized thinning of the cornea, that means usually dry eye is kind of advanced. One clever tool using OCT as well to look at the conjunctival chalaces. You can measure them. To your meniscus height, you can measure it. So you got a device really give you a lot of information to monitor treatment, monitor response to treatment, and inform the patients. So I'll finish by the this is just a couple of cases, but just show you that this patient got nice thick glands, less number density, but he got a very bad blockage disease. So this patient probably might benefit from probing. This is kind of where you decide what treatment I want to do. So in summary, right? So there is the only relevant index so far we know is how long is the gland. Intensity, have to see what's going on. Look at the upper lid, mammography, this is very, very informative. And think about epithelial mapping, adding into the picture, which you heard about it earlier today. Thank you very much.
So Samir, just give us a second. Yeah? Oh. So you've just described the science of meibomian glands, which is very interesting, and all the different configurations and what the tip-offs might be. But on a very practical basis, the treatment options are fairly limited, right?
That's it. It's very limited because we don't understand the disease itself from the start, and despite doing a lot of efforts, it's still defined, the definition has not changed. It's still defined as inflammatory condition, ocular surface disease. When it comes to management, I think the key thing, as you said here, you look at the morphology. So if a gland looks like it's threatened to be lost, this is where you need to crack on with IPL or anything you think might restore this function. If there's inflammation, it's anti-inflammatories, especially cyclosporins, tacrolimus, Xiidra, etc. If the meibum is an issue, you need to find what's going with the meibum. Is it a blockage? I mean, I don't fancy probing, but a lot of cases actually, they need a gland open. Now, the way we do it blindly is not the great ones. Maybe in future, OCT guided probing could be happening. I mentioned things to Francesco is about having a grading system different. So the grading system give you actually correlate the shape, morphology of the glands compared to normal, what it looks like. That'd be better, more informative about what the diagnosis, grade, and then targeted treatment.
So you see, I got a lot of gray hair, right?
Yeah.
And that's from from these sorts of patients, but doing this business for a long time.
Yes.
And
well,
for me, there's only three things for meibomian gland disease: omega-3 supplementation, no matter what level; IPL, if they don't respond to the meibomian gland, omega-3 supplements, and anti-inflammatory agents.
Yeah.
In the worst case scenario, the hardest thing to decide is, do they have inflammation or not? If there were marker studies that were really, really good, that would help us a lot.
Yeah.
But for me, that's it. I don't use tetracyclines and all these other things.
Yeah.
Just omegas.
I agree with you. That's why I didn't talk about all these other things, tetracycline, etc. One of the things is control. Sometimes you have to do two arms of treatment: inflammation and, for example, management dysfunction. Some people just do IPL, but the inflammation is there. So I don't think you got the full picture of managing disease.
Yeah. The meibomian gland, the blink exercises. Do you want to describe that for the audience? What a blink exercise is?
So
physiotherapy for the meibomian glands, right?
Yeah, well, I ask the patient to blink 5-6 times, 2-3 times a day. Just have a break, do full, and that actually express your glands, and you help the blink. And you see those with the blink lagophthalmos, they get much better. They're full closure. Just remind me one thing. When I was a fellow with you, Shiraz, we used to walk around the clinic, and you hold the cotton pad, right? And you squeeze the glands, and you tell me, I'm treating them now. I didn't understand that time what you're referring to. This is a long time ago. It's therapeutic. It's expression in the glands.
Free. So our blink exercises are the following. It's a patient who taught me this. Close your eyes tight and hold them there for 10 seconds. And do that 4 times. And then do the whole set 4 times a day. And what that actually does is it resets the proprioceptors. Yeah. For when they know they've blinked. Contact lens wearers are the worst when it comes to blink lagophthalmos. Yeah. So a few pearls of wisdom.
Yeah, lovely.
Anybody have any questions? Great, thank you.
Thank you very much.
That was great.
So the last talk is from Eric Mertens. Tears before clarity, why the ocular surface matters in IOL power accuracy.
Thank you, Victor. Thanks again for the invitation. And thank you, Samer, for the introduction, because your talk is great for the introduction of my talk, because I can give some advice you can use at home in the clinic. Now, this is my statement. If you don't know where you're going, you'll end up someplace else, and I will explain it to you. So what are the most important tests to rule out dry eyes in the office, in the clinic? You can use a Schirmer test, you can use tear breakup time, fluorescein staining, osmolarity of the tear film, and meibomography, as Samer pointed out, and epithelial thickness maps. Of course, you cannot do everything, because when you have a busy practice, this takes a lot of time. But why is it so important? It's very important when you will do refractive surgery, when you do corneal refractive surgery or full range of focus implantation, you need to have a good surface. This is, for instance, a topography treated with steroids, and you see that even after 1 week, that topography changed completely. So what do I do in my clinic? And I call it the Dry Eye Express to save time. So you can do the OSDI speed questionnaire already, you can give it to your patient, or when you do an MS-39, there's inside, there's also a questionnaire. The optometrist can do the measurement and do it together with the patient if you want. I stopped doing tear osmolarity for different reasons, because it's very sensitive. When you do not do it as the first test, the tear osmolarity will change in between 5 minutes. Did the patient take out their contact lenses? Did they put in drops by themselves before entering your clinic? And on top of that, it's expensive. So for me, I stopped doing tear osmolarity. The non-invasive breakup time, I think it's important. The epithelial thickness map and the meibography. All of this makes sense. The non-invasive breakup time is measured by different machines, also the Sirius and the MS-39 of CSO, of course. So this is how it looks like. You ask the patient to blink a couple of times and then open their eyes as long as possible. And the graph shows you when the tears break up and what is the average and so on. So you can have an immediate look at it, at the map, how the tear film behaves after blinking. The second very important technology is the epithelial thickness mapping, also a lot of OCT-based or ultrasound-based. And the MS39 again is giving us a 10 millimeter epithelial thickness map diameter. Why is it so important? Because the human corneal epithelium is really, really a very stable one in healthy individuals, in healthy corneas. Now, I try to do a preoperative classification of dry eye, and I think maybe we can incorporate it together with CSO in the future. What will be dry eye, the thickness maps in mild, moderate, or severe. I will show you the first stage is thickening of the epithelium. When you have a little bit of dry eye, a mild dry eye, what does the epithelium do? It starts to thicken. As you can see here, it's thickening. In most patients, also the epithelium is a little bit thicker inferiorly than posteriorly because of the movement of the superior eyelid. When we go further, when it is a moderate dry eye, the epithelium starts to thin, and you have a severe dry eye, you have extreme thinning of the epithelium. This is when you get when you fluorescent staining of the epithelium and the dead cells. Now, how severe is this? When you look at this, the non-invasive breakup time, I'll normally ask the audience, what do you think of it? Is this a severe dry eye, moderate or mild? You cannot tell because this is a moment. This is a moment in time where you measure the non-invasive breakup time. It can be completely different 1 hour before or after the measurement. So we have to combine this with the epithelial thickness map. So actually, this was a very severe dry eye. Why was the non-invasive breakup time not so bad? Because the patient used artificial tears before stepping into the clinic. But we diagnosed it because of the epithelium, the thinning of the epithelium. How severe is this? Same thing, we look at the epithelial thickness map. It's a mild one because it showed us thickening of the epithelium in these cases. And this one, when you look at it, it's like, oh shit, this is a very severe dry eye. But when you look at the epithelial thickness map, it's not severe, it's just moderate. So why is this so important? So for me, the non-invasive breakup time is a snapshot. A snapshot, yes, it's like glycemia. When you measure the glucose in the blood of the patient, it's the glucose level, the glycemia at that point in time. While the epithelial thickness map is more like the hemoglobin A1C to see what is the evolution of the glucose in the blood of the patient. So you look back into the past. So the combination of both gives you a very nice view of how dry eye those patients' eyes are. So you have to treat it before doing pre-op examinations. When the patients come in, we see this kind of thing, as Shiraz pointed out. We give them omega-3 supplements, non-steroidal, anti-inflammatory drops, and IPL if necessary. So this is very important. Why? Because when you're doing refractive surgery in general, spectacular achievement is only preceded by unspectacular preparation. And I will show you. This is one of my patients, came in for a pre-op examination. We found a non-invasive breakup time not that bad, but when you looked at the epithelial thickness map, it was already thinning. So we treated it. We let the patient come in after 4 weeks. We found a very nice non-invasive breakup time, and the epithelial thickness map was nice. So then we did the IOL master measurements. And look at this. When you look at this, you can see for the left eye, this was measured in April 5, 23, and this was May 15, 23. Just look at the measurement, the calculation. So of course the actual length is the same, 24.43, 24.42, of course. But when you look at the keratometry reading, 41.6 without treatment of the dry eye and 40.6 almost 6 weeks after it. But when you look at the lenses to be implanted, you can see that when you do not treat the dry eye before the measurement, you would have implanted a 20 diopter lens with a +1 at 106 degrees. And actually, you should have implanted 21.5, one diopter of cylinder at 145 degrees. So not only the dioptrical power changed, but also the axis of your toric IOL implantation changed. So you would have ended up with a bad postoperative result. So I think the epithelial thickness map and the non-invasive breakup time, which is measured by the MS39, is a very sensitive tool in diagnosing dry eyes. It helps to avoid surprises in premium IOL surgery. It helps to plan your treatments for corneal refractive surgery. It helps also in customizing the type of refractive surgery, and it gives also important information in special cases. So the mybography, I will not go into this because this was already covered by Samer extensively, but it's very important. Why is it important? Because I found out when I showed my patient like epithelial thickness maps or non-invasive breakup time maps, they looked at me like, yeah, and then what's that? But when I showed them their mybography and showed them a normal mybography, they understand that something is going on with their body. When you're losing a body part, because yeah, the meibomian glands are a body part, then they understand it's very traumatic for a patient. So I lost my meibomian glands. Oof, there's something going on. What can we do about it, doctor? Then they start asking questions. So the mybography helps me to explain to the patient that the dry eye is very important. So pre-op testing and adequate treatment is key to get good results. Because when you look into literature, what is predominantly for the satisfaction after cataract surgery of patients, it are the dry eye symptoms. Dry eye symptoms are more closely associated with patients' postoperative satisfaction than the measurement of visual acuity. It's very surprising, but it's proven here in the literature. So in conclusion, we can say that you need to test all patients preoperatively, whether young and old, all of them, they undergo non-invasive breakup time testing and epithelial thickness maps. For me, my post-surgery satisfaction rate is now 93% 1 month post-operatively, so 4 and 5 out of 5. And it was 76% previously. And also very important, my treatment rate by incorporating this in my practice dropped from 11 to 3%. Thank you very much.
Thank you, Eric. There's great points there. Victor, do you want to make any comments at all?
Yeah, I just would like to add that it always makes sense pre-cataract surgery to look at also the OCT raw image, because we very often in dry eye we miss the basement membrane dystrophy, which masks behind. So if we look at the stromal elevation map in combination with the epithelium and the raw OCT image, we can determine it well. So
yes,
sometimes patient needs a PTK to solve this.
Exactly, I agree fully. Yeah. But I just highlighted, I do more tests, of course, but I just highlighted the epithelial thickness maps and non-invasive breakup time.
So it's a good message. If you don't treat the dry eye, if the patient has dry eye before surgery, it's their problem, right?
Yeah. Yeah, well.
But if you don't take care of it, it becomes your problem.
There's another thing also which is very important. When you do not stress to the patient that they have dry eyes, but they don't have any symptoms, they will get symptoms after your surgery and he will blame you. Mr. Daya, you fucked up.
You created it.
Yes, you created it. No, it was already there. But when you do not tell it before surgery, you are the villain. And now you can talk to them afterwards. Oh, guys, I told you before surgery you have dry eyes. So this is also it is psychologically very important that they know before surgery.
It's also a great bonding mechanism with patients beforehand.
Yeah.
When you start to tell them they've got a dry eye, and you put them in omegas, you tell them to do warm compresses. No, I'm not touching you for the next 2 months.
Yeah.
And you've got to be better. That means you've got to do what I tell you to do if you want the surgery. And it's a great relationship builder as well. So.
Yeah.
And then if they do have a problem afterwards, well, we talked about this.
I told you. Yeah. Good.
Great. No comments. Very quiet audience. Nobody has any comments or questions? Okay, well, I think we're really appreciative of CSO for hosting this and for having this users meeting. Been a great education session. And Francisco is going to conclude by telling us what's next. So on behalf of everybody here, we'd like to express our gratitude to yourself and Gilda, the whole team at CSO. Great location, great hospitality.
Thank you.
Great topics.
And the great cook.
And we're looking forward to more great products.
No, on the contrary, I have to thank you all for staying to the last point. And of course, for joining us, it was a great pleasure. So I promise I will stall you just 3 minutes, and I will talk about what we are working on, and what you can expect from us in the next months. So first of all, the new version of Phoenix is now ready. So as you know, it contains everything about ocular biometry, so IOL formulae, and also DICOM full compatibility for the one of you who use DICOM. The high-CL sizer is now officially available. You can download it and install it. And there is also a very nice enhancement in OCT images, either both for contrast and for the crystalline lens alignment, so better images. And this is already the present, but what about the future? Okay, we heard that finally the wait is over, and we have the new TFOS DU3, and for this reason we have to somehow update our software to be aligned on the latest changes. So the dry eye report workflow will be updated. We have to implement, we used to have the OSD, now we have to implement the OSD6, which will save your time because it's a shorter test. And of course, we have to add something that is nice, and is the blinking rate test. And according to some information, we have to also update the grading of mammography. Then we can discuss some what do you think about that and how you would implement this. This one is nice. I hope the image is pretty, yeah, I don't know if it's fully visible, but I hope so. This one is a normal OCT image. You can see that it's nice, great, but there is some speckle, okay? So we have been working on this for a long time. So we are trying to create the speckle algorithm able to turn the image from this to this. And this is just done by the device itself. It's not an average. So we can despeckle the image and move from this to this with more details from a noisy speckled image to a smoother image. You can also see how nicely we are able to pick up the Bowman and the endothelium that were almost invisible on the left image, but now are visible in the second one. So this doesn't work only for normal corneas, but also for a very bad image like this. This one is the outcome. So, and now the question is how we spend this advantage. So we could do more scans, for instance. Instead of 25, we can scan 50 scans, or we can have half of the time. So instead of 1 second, 1 second and a half, reduce the time of the scan to half second, or do a super scan, averaging the speckled images. So maybe you can advise us about how to use this. This is another point. So probably all you know about this great presentation from Renato. Very good indeed. And you know that the main reason of the quality of OCT, Oculus OCT scan is the way they scan the eye. So it's not the resolution, because it's almost comparable, but it's the way they're scanning, okay? You also know that this takes some big disadvantage because we have, they are forced, they cannot measure with OCT, but they just measure the epithelium and the thickness with OCT, and all the rest is done by Scheimpflug, which is unacceptable nowadays. But if you are really keen of seeing parascientific images, we could help you by providing a tool, okay, that you can just place in front of your device and achieving this sort of image. So this one is a Fuchs dystrophy, for instance, and you can see how good is the quality here. Or yeah, this one is another case. So you don't need to have a full dedicated device to get these images. It's enough to apply a nice optical extension to your OCT to get this kind of image. One more topic, specular microscopy. You know, is very important, is crucial. You know that in Italy it's mandatory, in most of Europe is highly suggested, so is highly, yeah, you should do this kind of exam before cataract surgery. But not all customers have space, or not all the customers have money to buy a device like this, but all our customers have this device. And what about a specular microscope that who fit your slit lamp like this? So this is possible. We are going to show you something like this in Copenhagen at the HRSS. And based on this kind of scan that is partially half manual, half automatic, because the XY alignment is done on the slit lamp, but the Z alignment is done on the device, you could obtain this kind of image, and in small space and probably with less money, you could have a very good image of the endothelium. We have to thank yesterday Shiraz and Tom for their insight of the 3D stereoscopic slit lamp splitter. We think that the world of slit lamp is changing, and absolutely we agree on their vision, and we are fully on board with them to drive this change. We also have a discussion with Farhad about the pace, so we are ready with our device for delivering the pace software. We are just waiting for the publication, and then all of you could have this wonderful approach, surgical approach, and start doing your surgery. We also talk about the Chi index with Riccardo and the solo sizing with Eric. So this is something that it is in the pipeline, so something that we have to do. And with this, I would just quote a beautiful movie, so The Hangover. So now you see me on the podium, but it's not just me. So this one is my wolf pack. Okay, so this is the R&D team that work together with me on all this beautiful stuff. And with us, we have people on the front and back office and front office helping us and making all this stuff possible. So thank you to everybody. Thank you to CSO management for allowing us doing this kind of activity. And I want to see you all in Copenhagen for our Breakfast meeting in September. Thank you.
Anybody have any questions or any ideas for the future for CSO?
In private.
In private, okay. All right.
Thank you again.
Protect your IP. Thank you very much.
Thank you all again for being here. The one of you that have to leave with the shuttle is down waiting for you. Thank you again.